Yes, ma'am, we are live now. Please start.
So good evening, seniors, friends, ladies and gentlemen. Welcome to the Caesarean section workshop today, organized by Dr. Sadhana Gupta. For an obstetrician, Caesarean section can be an experience like a heaven as well as a hell. So situations sometimes can be very unpredictable, difficult and challenging. So we are spending the evening today to have an update and enrich our knowledge on a very common procedure, yet a procedure where we can always fall in trouble if fate is bad on that day, that is Caesarean section. I invite Madam to welcome our chief guest. Before that, we shall start with a prayer.
Ma'am, please unmute, ma'am.
Dr. Sadhana Gupta, Madam, the chief organizer today, is co-chair Suffolk NCD Committee, Foxy representative to Suffolk, Vice President Foxy 2016, ICOG Governing Council member, author of many books and research papers, and key organizer of national and international conferences. I request Madam to invite our chief guest, Dr. Manju Geeta Mishra, Madam, and our guests of honor.
Thank you, Moshmi. And first of all, gratitude for all the effort of the Bengal Society, Dr. Avinash, Dr. Vishwajit, Dr. Meena Samant, Dr. Amita Sinha, that we are together for intricacies and complexities of the cesarean section in next 2 hours. So gratitude for everyone, because only because of your effort, we are together on yet another interesting session. A little bit about this E-Classic for clinician, which the word I coined around 1.5 years ago, because we got that feedback from many teachers, like great teachers like Dr. Ram Prasad, Himali, Ashish, Dr. Manju Geeta Mishra, so many teachers we have delivered that today the young generation is arguing with their teachers that it is evidence and it is this thing. And they emphasize that there must be a very strong foundation of the basic and the classical teaching, which actually makes the strong foundation and on which we can inculcate and imbibe that what is our research and how it is doable, reproducible in our setting, and what are our experiences with this. So that is like a classical, like a Bengal and Patna is something which had a great like a fascination for the classical music, and that is the thing that what we have, the saat surgam pe hamari pakad hogi, to uske after that we can create a lot of like newer like modalities raga, but we must have a very strong foundation for our basic soul. So this was the aim for all these series of the E-Classic for clinician, and I owe a big gratitude that we are having around 60th series today. With this, it is a great pleasure to have the teachers of teachers, Dr. Manju Geeta Mishra, whom we see as a great mentoring figure, not only in the eastern part, but all over the country and across the country. Dr. Manju Geeta Mishra has been a very strong association. She has come so many times. Always she is there to grace our conferences and the program. For introduce her formally, she is the present consultant MGM Hospital and Research Center, doing so much of work at this age of and at this seniority. She has been the ex-professor, Patna Medical College and Hospital, Patna. Her students loved her, loves her, we adore her. Past President IMA Bihar State, Vice President IMA All India Women's Doctor Wing, present CWC member, President ISOPAR, she has graced the position, and the Chairperson Medical Education Committee. We still remember her wonderful tenure, delivered many oration, guest lecture, contributed chapter, ardent academic writer, and more than 70 publications in various national and international journals. A warm welcome, Madam, and thank you once again for being with us today. And we look forward for your words of blessings from you.
Thank you, Dr. Sadhana Gupta. Very good evening to each and all. So first of all, I must congratulate Dr. Sadhana Gupta for organizing this wonderful seminar, that is Caesarean section workshop, because under the aegis of Bengal as well as Patna OB-GYN Society. So she has chosen all the senior members of the society, such as Dr. Ashish Mukhopadhyay, Dr. Alka Pandey, Dr. Pramila Modi, Dr. Neelam, and Dr. Ram Prasad De. So I think that this we will have a very good input. After hearing from all the members, we can come to a consensus of how to when and how to do cesarean section, because we are WHO has proposed a Robertson classification as a global standard for assessing, monitoring, and comparing cesarean section rate within both within and after. So the characteristics of that is parity, number of fetus, previous cesarean section, onset of labor. So because we see that these days many doctors from periphery, they are doing so much of cesarean section without any indications. So and thus by doing cesarean section, the rate of PAS, placenta accreta syndrome, has increased so much. But in my practice, I see many patients coming from periphery with PAS, and then it becomes difficult how to manage the PAS, and many times patient needs hysterectomy. So we must do the proper counseling when to and proper assessment, and then only we put the patient for this cesarean section, because maternal mortality rate in emergency cesarean delivery is 9.7 per lakh deliveries. So this is very high. So with these words, once again, I thank Dr. Sadhana Gupta and my best wishes for her future election. And I thank her for because she has invited me for this wonderful seminar. Thank you very much.
Thank you, Madam, for your pulse of wisdom and a caution, word of caution, and above all, your precious wishes, which is invaluable to us. Thank you very much, Dr. Madam. And it is a great pleasure to have Ashish, a very close friend in journey of Foxy, and his company is always so wonderful. He has a brilliant sense of humor as well as a brilliant teacher, academician. He sings so well, he plays so well. So what to say about Ashish? Although formally he is a principal and professor, unit chief, OB-GYN, CSS College of Obstetric Gynae, Child Health, Kolkata. He has been the vice president Foxy 2016. I was fortunate to have, we are together as a vice president and enjoyed a lot, right from election process to the whole year. Governing council member, he has been past president Bengal OB-GYN Society and ex-chairperson. Again, after Madam, He was also a person who made his mark as a chairperson Medical Education Committee Foxy and the scientific chair of a wonderful organized conference which we enjoyed in January 2023 and WHO Fellow Maternal Health. So Ashish qualities are numerous. Beyond his academic contribution, he has so much thing to give to his friends. So Ashish, we are looking forward to hear from you.
Namaskar, everyone. Thank you very much, Sadhana. Yes, we are very close buddies because we grew up together in Foxy as vice presidents together sitting on the dais and sharing those moments of wisdom in Foxy for 1 year. And Sadhana, I can tell you, I don't know how much you know about Sadhana. I'm sure you know a lot more about me, her than me, but she's a wonderful personality. And that is reflected by her choice of subject today. Even Caesarean section today is a grassroots level subject. Everybody is doing Caesarean section, and she is also a grassroots level worker. I have seen Sadhana working from the grassroots level and growing up in stature, day over day, night over night, and year over year. Sadhana is a relentless worker and also a keen thinker of Foxy. And I believe that Foxy can move ahead with the help of this kind of people. Truly majestic lady, Dr. Sadhana Gupta. I think, Sadhana, your topic selection has been fantastic. And I have been reading parts of your wisdom that you circulate every now and then, every week. I think you have already taken out 36 versions of this. I am a silent reader of that. I don't tell you, but I really read silently. And they are really containing the pearls of wisdom. So what to say about your journey in Foxy? We all know about that and we feel for you. And I think that we will all best wish to you for your journey. And whatever happens, you are an epitome of the proverbial truth that the journey is the actual thing. Success or achievement is not. I think this is one thing which we all should learn from Sadhana. And I would like to wish from a core of my heart all success in your lives. Thank you very much, Sadhana. And I believe that today's discussion on Caesarean section, looking at the contents, it will be immensely useful and beneficial, not only to the panelists like us, but also to the common people or lay doctors who are waiting outside this arena. They'll be benefited. Thank you very much for inviting me over here. It is a real pleasure being over here and meeting all of you. Thank you so much.
Thank you, Ashish, joining from Jorat, and your very loving and precious wishes. I'm really overwhelmed with your all words. Thank you, Ashish. Thanks a lot. And we always look forward to work with you for years together. Dr. Alka Pandey is our guest of honor today. Dr. Alka Pandey has been, again, I have been very, very closely associated with her, and she appears silent, but she does so many organized work. And we just had a vice president conference at Patna, wonderfully organized, taking all the issues which can be very, very pertinent and important for our setting. Dr. Alka Pandey is Associate Professor in Patna Medical College, Patna, Vice President. She is currently Vice President of Foxy and Member Governing Council, ICOG, Chairperson, Practical Obstacle Committee. She has done a lot of publication as a chairperson and did a so impressive work. National Corresponding Editor of Jogi and President Patna Obsgynae Society. She has graced the position from 2012 to 2014 and Joint Organizing Secretary for yet another memorable AICOG 2014 and Organizing Chairperson, this Boxcon 2014. A warm welcome, Alka-ji, and it is such a great pleasure to have you here. And
Thank you, Sadhana-ji. Thank you, Sadhana-ji, for your kind words. And respected chief guest, Dr. Manjugita Mishra Madam, Dr. Ashish Mukherjee, sir, Dr. Pramila D, Dr. Avinash, Dr. Vishwajit, Dr. Rita Jha, Dr. Meena Samant, Amita, Dr. Mausumi. Every one of us has witnessed Dr. Sadhana Gupta working tirelessly for Foxy. She has organized this webinar on Caesarean section, which is a very commonly performed operation these days, and it has a lot of drawbacks also, and probably it has also good points also. So we are going to hear all about the cesarean section today. And Sadhana ji also has edited a book on cesarean section, which we have with us. And we go through it also at times. And Sadhana ji, I wish you all the best for your coming elections. You are really a very good worker, and Foxy will be proud to have you. Thank you. Thank you, ma'am.
Sadhana, you are muted, yes.
Yes, thank you. Thank you, Madam Dr. Manju Gita Mishra, Ashish, and Dr. Alka Pandey for your great words of wisdom and your precious, invaluable wishes. Thanks a lot.
So with the blessings of our chief guest and guests of honor, we now move to session 1. This speaker is Dr. Queen Aditya. May I introduce the chairpersons? Dr. Neelam. She is the medical director and consultant, Santati Fertility Clinic and ART Center, Arvind Hospital, Patna. She's consultant in Sadbhavna Clinic, Patna, Vice President, Patna PAR, Vice President, Patna Menopause Society, Joint Secretary of Indian Fertility Society, President of Obs and Gynae Society 2019-20, Organizing Chairperson of BoxCon, then LabourCon, co-author of many chapters and books. We have with us Dr. Rita Jha, Madam, as a chairperson. She is the ex-associate professor of PMCH Patna, Vice President-elect National ISOPAP 2024-25, Vice President ISOPAP Patna Chapter 2019-21, Executive Member of ISOPAP, Executive Member of Patna Obs and Gynae Society, Chairperson Quiz Committee, Working Member Committee of PMS.
It's okay.
And we have also with us Dr. Ram Prasad Desar. He is the editor-in-chief of Indian Journal of Perinatology, National Executive Member of ISOPAP, corresponding editor in Jogi, recipient of many Foxy Awards, like Mrs. Chandravati Devi Award, Golden Jubilee Swisera Award, and he is the examiner of MBBS and DGO exams with multiple publications to his credit. I request Dr. Neelam to introduce our speaker today, Dr. Queen Aditya.
Thank you, Saitya, for your wonderful introduction. And am I audible?
Yes.
Yes, madam, you're audible.
Yeah, I would first of all, I would like to thank the organizers for giving me this opportunity to be in this wonderful workshop. I really congratulate Dr. Sadhana Gupta for her untiring efforts and wish her all the success. And it's my proud privilege to introduce Queen Aditya, who is, I think she is beauty with brains. And it's wonderful to introduce her. She's MBBS honors and gold medalist, MD, and she has received APG Abdul Kalam Azad Appreciation Award from Delhi Gynecologist Forum in 2015. She has also received Chief Minister's Gold Medal as Best Female Candidate in Higher Secondary Exams conducted by West Bengal Board in 1988. And then she was actively worked for Foxy Breast Committee and Perinatology Committee between 2016 to 2021. She was subcommittee member of Bengal Obs and Gynae Society and currently East Zone Coordinator of Foxy Sexual Medicine Committee. That's really a good, very wonderful introduction. And I would like now Dr. Rita Jha to introduce the subject. I would request her to introduce the subject. And I'm eagerly waiting to hear Queen Aditya on the topic.
Thank you, Neelam. A very good evening to all of you. To start with, thanks a lot to the organizing team of this prestigious and important CME on this wonderful topic. And my special thanks to Sadhana ji and all the best for her election for the Foxy presidential candidate. And my thanks to Mosimi also for this invite and to be a part of this important CME today. And topic of this first session is indication of Caesarean section with a special reference to Robson's criteria. There are three most common adopted classifications, of which one of the classification is Robson's criteria, and based on 10 group classification, and which has been endorsed by WHO, as mentioned by Dr. Manjugita Mishra Madam in her address, as a global standard tool for monitoring and auditing Caesarean, as it is a simple, effective, risk-based, and widely accepted classification. We all know increasing cesarean section rates have become an important international public health concern. We all know the causes why it has been increased in the recent past, but at the same time, we also know the associated morbidity with it, which is about 4 times more common than in vaginal delivery. So, and most of the recent studies have shown that Robson's classification of all the Robson's classification group 5 and 1 and 2 are the most common indications, which is previous cesarean section and fetal distress. And therefore, it is a real challenge to decrease the incidence of primary cesarean section and as well the repeat cesarean section. So it is our responsibility to reduce the incidence of primary cesarean section, as well as we should promote VBAC in selected cases while taking safety for mother as well as for the baby. I'm sure Dr. Queen Aditya is going to enlighten us on the topic. And so floor is yours, Dr. Queen Aditya.
Thank you so much. Thank you so much.
And in the last, I think you will sing a song also.
Very kind of Sadhana ma'am to say so. Okay, thank you so much. So let me share my screen. Thank you so much, ma'am. Thank you, Sadhana ma'am, for having me here today. Thank you, everyone, for being here. Dr. Moshimi for arranging everything. So I hope the screen is visible. Just let me go full screen. I hope I'm audible.
Yes, yes. Yeah, audible.
Yeah. Yes, full. I'm waiting for the full screen. Yes. So we are talking about the indications of Caesarean section with special reference to the Robson criteria. We talk about a few other things as well, but especially about Robson's criteria, which has already mentioned by my esteemed seniors. So because I'm the opening batsman, I'll talk a few things about Caesarean section per se. So if you look at the definition, Google for the layman says a Caesarean section is a surgical procedure in which a baby is born through a cut made in the mother's abdominal wall and uterus. A baby will need to be born by Caesarean section if there are serious problems that prevent the baby being born by a normal vaginal birth. Point to be noted, please. Now, according to WHO in the 2017 publication, it was said a Caesarean section is a life-saving surgical procedure that can prevent maternal and perinatal mortality and morbidity. A little bit about the history. The early history of Caesarean section remains unclear still. At the time of Julius Caesar, the procedure was performed only when the mother was dead or dying as an attempt to save the child for a state wishing to increase its population. The Roman law under Caesar decreed that all women who were so fated by childbirth, that is, who were almost dying or dead, must be cut open. Hence the name Caesarean. That is one idea or thought. It is commonly believed to be derived from the surgical birth of Julius Caesar himself. But in that case, the mother was supposed to be dying or dead, but fortunately, his mother survived to see him rise to power. So that's why it is actually not that true. Anyways, the other possible Latin origins include the verb cedere, which means to cut, and the term caesons that was applied to infants born by post-mortem operations. Ultimately, though, we cannot be sure of which the actual one is. Until the 16th and 17th centuries, it was called a Caesarean operation, but much later, Jacques Guillemin's book on midwifery replaced the word operation by section, and it is continuing the same even today. So types of cesarean section, there are several, but if we go to the gross category, then it can be either elective or emergency. An emergency cesarean section can be subclassified into other categories based on their urgency. This is to ensure that babies are delivered in a timely manner in accordance to their or their mother's requirement. So the categories of cesarean section, which are according to RCOG, which we all know, category 1, 2, 3, and 4. Category 1 is when there is immediate threat to the life of the mother or the fetus, and it has to be arranged within 30 minutes. And in some countries, they even say 20 minutes. Category 2, where there is maternal or fetal compromise, which is not immediately life-threatening, but still requires a very early delivery, and the time limit has been kept as 75 minutes. And if not taken directly to the theatre, the case must be kept under regular supervision to review and to ensure that the category does not quickly change from 2 to 1. Category 3 is where there is no maternal or fetal compromise but needs early delivery, and category 4 is to suit the woman, staff, and everyone, mostly the elective forms. So examples of the category 1, that is the immediate urgent ones, are suspected uterine rupture. Some of the examples are suspected uterine rupture, major placental abruption, cord prolapse, fetal hypoxia, or persistent fetal bradycardia. Some of the examples of category 2 are failure to progress in the first or second stage of labor, failed instrumental delivery, non-reassuring fetal heart abnormalities, and so on. If we look at Williams Obstetrics, the current edition, the exhaustive list of the indications of cesarean, I can just read a few. Maternal indications are prior cesarean delivery, abnormal placentation. Maternal request has also made its way into the textbook. Prior classical hysterotomy, unknown uterine scar type, and so on. Then maternal and fetal both, cephalopelvic disproportion, failed operative vaginal delivery, placenta previa or abruption. Fetal can be non-reassuring fetal status, malpresentation, macrosomia, congenital anomaly, abnormal umbilical cord, Doppler study, and so on. These all, mind you, are from the current edition of Williams Obstetrics. Some of the indications of elective cesarean as per NICE guidelines are breech presentation, other malpresentations, twin pregnancy when the first is not cephalic, maternal medical conditions like cardiomyopathy, fetal compromise, as I've already mentioned, some transmissible diseases like poorly controlled HIV, primary genital herpes, especially in the third trimester where there has been no possibility or time for the development and transmission of proper antibodies. Hence, herpes HSV in the third trimester is also to be thought of. Placenta previa, which we all know. Maternal diabetes with the baby estimated to have a weight more than 4.5 kgs. I think ACOG nowadays is talking about more than 5 kgs. Previous major shoulder dystocia. Previous third or fourth degree perineal tear where the patient is currently symptomatic. And maternal request has also made its way to this list brought out by NICE. So this covers a variety of reasons from previous traumatic birth to just a plain choice. So we'll talk a little bit more about maternal request later. Some absolute indications of cesarean, some of the very many are central placenta previa, contracted pelvis or cross CPD, advanced carcinoma cervix, pelvic mass which causes obstruction like a fibroid which is totally in the way, vaginal obstruction like atresia, stenosis, and so on. According to ACOG, this 2011 population-based study, the most common indications or reasons that they found for primary cesarean delivery included, in order of their frequency, was labor dystocia, abnormal or indeterminate, that is formally non-reassuring fetal heart rate tracing, fetal malpresentations, multiple gestation, and suspected fetal macrosomia. So ACOG in 2011, they found out these to be the amongst the commonest causes of a cesarean section. And they also came out with a lot of, they studied several cases and found out that these might be a few ways in which they are able to reduce the rate of cesarean section. When we talk about arrested first stage, then probably they mentioned judicious augmentation by oxytocin might actually prevent a cesarean section. Prolonged second stage is something that we used to say more than 1 hour in a multi, more than 2 hours in a primary, but they are saying that even in the first stage and also in the second stage, probably the human body has adapted somewhat differently nowadays compared to several years or decades earlier. Whether we are progressing or regressing, I really cannot say, but they have noticed, because they wanted to reduce their cesarean section rates, and so they found out that if we leave the mothers to themselves or judiciously augment them, then probably we will be able to reduce the rates of cesarean section. So they also said that in case of a prolonged second stage, we can give a bit more time. Instead of 2 hours, if when we are monitoring all is going well, we can wait maybe half an hour more or so, provided all the parameters are going okay. They are also talking about operative delivery, whether that is a forceps or a ventouse, wherever feasible, to prevent that cesarean section. And even they are talking about manual rotation of the occiput in transverse or posterior positions. Now, again, when we were talking about the abnormal fetal heart rate tracings, they also said that we should assess which abnormal tracings actually need a cesarean section, and only the category 3 that they have mentioned are the ones that might warrant a cesarean section, not any and every kind of abnormality. Temporary abnormality is not something which should make us jump towards a cesarean section straight away. Again, they were speaking about malpresentations, and so they have again mentioned judicious use of version at 37 weeks. They have spoken of at 37 weeks in breech. And it has been seen excessive maternal weight gain can also cause problems and eventually lead to cesarean section. So avoiding the excessive maternal weight gain can also be of prime importance. Encouraging vaginal delivery in twins with the first twin in a cephalic position. So when that has been noticed, then it is better that we let the woman go into spontaneous labor. And another thing that they have noticed is that when there is continuous labor support by someone especially there to give the woman support throughout, then the possibility that the woman will go through the entire process of labor and finally deliver vaginally, the possibility and the rate is much higher. And therefore, they are also advocating continuous labor support. Now, we had already mentioned the abnormal fetal heart tracings, which need urgent intervention. According to ACOG, they spoke about the category 3 fetal heart tracings, which include either absent fetal heart rate variability with recurrent late decelerations, recurrent variable decelerations, or bradycardia, or a sinusoidal rhythm. And they have been associated with abnormal neonatal arterial umbilical cord pH, encephalopathy, and cerebral palsy. And these cases need immediate intrauterine resuscitative efforts. If there is no improvement, then immediate delivery is required. And in most of the cases, that will end up in cesarean section. So they have categorically mentioned these findings. Now, WHO in 2015 was alarmed by the rising trends of cesarean section. They said that over the last decades, the use of cesarean section as a mode of delivery has been increasing to unprecedented levels, with parallel concern about its consequences. In order to understand what is driving this trend and propose and implement effective measures to ensure that it is not being used unnecessarily, a tool to monitor and compare cesarean section rates in the same setting over time and between different settings was needed. Then came the Robson classification. So in 2015, WHO proposed the use of Robson classification, also known as the 10-group classification, as a global standard for assessing, monitoring, and comparing cesarean section rates, both within healthcare facilities and between them. The Robson's criteria classify all deliveries in 10 groups on the basis of 5 parameters, that is parity, onset of labor, fetal presentation, number of fetuses, and gestational age. And as my seniors have already mentioned, the previous cesarean is also one of the very important issues out here. WHO expects that this classification will help healthcare facilities to identify and analyze the groups of women which contribute most and least to overall cesarean section rates, compare practice in these groups of women with other units who have more desirable results, and consider changes in practice. Assess the effectiveness of strategies or interventions targeted at optimizing the use of cesarean section, assess the quality of care and of clinical management practices by analyzing outcomes by groups of women, and assess the quality of the data collected and raise staff awareness about the importance of this and its interpretation and its use. So coming to the actual Robson's 10 group classification, WHO 2015. So the group and the description is that group 1 is the nulliparous singleton cephalic full term spontaneous labor. The second is nulliparous singleton cephalic full term induced labor or pre-labor cesarean section. 3 is multiparous singleton cephalic full term without a previous cesarean section, spontaneous labor, and so on. Very important is 5, which is multiparous singleton cephalic full term with a previous cesarean section, and also number 10, that is singleton cephalic preterm. These are the very important groups. Now, if we go to, we have several studies which have analyzed cesarean section or the pattern in which it is done based on Robson's 10 group, and I'll just mention a few. This particular study by Rashida Parveen et al. Mentioned that as per Robson's 10 group classification, group 10, that is the premature, and group 5, that is the post-cesarean, were found to be the most contributing amongst deliveries done. Previous cesarean section and fetal distress were the most common indications of cesarean in their series. Now, this other study by P. Gautam in Nepal, they found that group 2 in their study was quite important and one of the highest contributors to cesarean section, and group 2 was induction without spontaneous onset of labor. This study by Vogel et al. In 2015 across 21 countries, they found, they studied countries of all HDI groups. And they found that women who have previously had a cesarean section are an increasingly important determinant of overall cesarean section rates. Therefore, implementation of evidence-based strategies avoid medically unnecessary primary cesarean sections. And to encourage the safe and appropriate use of vaginal birth after cesarean section, they have also advocated the same, which my previous seniors have also mentioned. Indication for cesarean section as per Robson's criteria, an analysis of 5,000 consecutive cesarean cases in Mumbai by Dr. Basir. They also found that as per Robson's criteria, group 5, that is the previous LSCS, remains the main indication, and followed by group 2, again, nulliparous, not in spontaneous labor, where induction has been done. So these are points to be noted. Now, this point on CS on maternal request, ACOG 2022 has mentioned that when a woman desires a CS on maternal request, her healthcare provider should consider her specific risk factors such as age, body mass index, accuracy of estimated gestational age, and so on. And in the absence of maternal or fetal indications for cesarean delivery, a plan for vaginal delivery is safe and appropriate and should be recommended. After exploring the reasons behind the patient's request and discussing the risks and benefits, if a patient decides to pursue a cesarean, then the following is recommended. In the absence of other indications for early delivery, then go ahead at 39 weeks only to prevent respiratory distress. And given the high repeat cesarean delivery rate, the patient should be informed. Very, very, very important, this point is that they should be thoroughly described this particular point, that the risks of placenta previa, placenta acreta spectrum, as our chairpersons and guests of honor have already mentioned, and gravid hysterectomy as well, increase with each subsequent cesarean delivery. So the patient who is requesting for a maternal request for cesarean, they have to be repeatedly told about these things, and only once they understand that they are now subjecting themselves to this kind of risk, should they finally say that, yes, I want to go for a cesarean section, though I don't have any other indication. So this is a very, very important point. So WHO position on childbirth is that the cesarean sections are effective in saving maternal and infant lives, but only when they are required for medically indicated reasons, as the Google definition is also mentioning the same. At population level, the cesarean section rates higher than 10% are not associated with reduction in maternal and newborn mortality rates. Cesarean sections can cause significant and sometimes permanent complications, and so we have to keep that in mind. But however, WHO at the same time is saying every effort should be made to provide cesarean sections to women in need, rather than striving to achieve a specific rate. So we are always talking about rate. WHO is also talking about rate, but someone who is definitely in need, in dire necessity, they should not be denied a cesarean section. This is something also we have to keep in mind. So limiting the cesarean section rate in low-risk pregnancies is key to lowering the trend of increased abdominal deliveries. This observational study by Delbert in 2012 they again spoke about the primary, the nulliparous woman who is being subjected to cesarean. So that is something we have to keep in mind, trying to prevent the primary cesarean. So to conclude, I would like to say that cesarean section is an extremely important surgery, as all our guests of honor, chairperson, everyone have mentioned that it is absolutely ingrained in us and it is part and parcel of our life, because we have to save many women and many babies by a cesarean section. But it is an extremely important surgery which by definition is supposed to be used only when vaginal birth is not feasible for that particular case. Knowing the hazards of a cesarean section, we need to avoid it wherever it's not absolutely indicated. At the same time, we shouldn't deny a woman a cesarean section where it is necessary only in order to keep our rates low. That is 10 to 15% according to WHO. Indications are many, and the category system guides us with respect to urgency as category 1, 2, so on. 1 within 30 minutes, 2 within 75 minutes, and so on. Cesarean section on maternal request, which has now found its way into our textbooks as well, though commonly sought, needs adequate counseling about future consequences. The woman is asking for a cesarean, but she does not know what she has in store. We have to make them aware that yes, you are asking for a cesarean today, tomorrow, these are the consequences you might have to face. According to Robson's criteria, several studies show that post-cesarean as well as induction of labor are amongst the commonest causes of cesarean section. Now, the cesarean section rate has been found in many studies as 26% after induction, vis-a-vis only 12% in spontaneous labor. Some studies have shown that the cesarean section rate is almost parallel in both, but most of the studies have shown the cesarean section rate is much higher after induction, wherever there is not a spontaneous onset of labor, wherever we are inducing on our own. Observing several studies, keeping Robson's classification in mind and following ACOG and RCOG suggestions, trying judiciously and patiently for a vaginal delivery after allowing a spontaneous onset of labor, trying to avoid the primary cesarean section and avoiding unnecessary induction of labor wherever feasible should be our goal. But once again, wherever a woman is in need of cesarean, either for her or her child's benefit, there we cannot deny. We have to remember that WHO has asked us to keep the rate between 10 and 15%. We will try our level best, but whenever there is a genuine need, we will definitely go ahead and perform the cesarean section. And I thank you so much for your patient listening. Thank you so much, Pranav.
Thank you, madam, for a very elaborate presentation. I request Dr. Ram Prasad Desai, please comments.
Good evening. Am I audible?
Yes, sir.
Yes. Thank you, Dr. Queen, for beautifully elaborating the. Before going to the topic proper, I must thanks to Dr. Sadhana Gupta for inviting me for the cesarean section workshop. And it is my privilege and honor to have with this dais where Dr. Manju Gita Mishra is the chief guest. Now coming to the subject proper of cesarean section and 10 group Robson criteria. Dr. Queen has elaborately described the categorization of the cesarean section from NICE, different critical analysis of the elective cesarean section, as well as the emergency cesarean section. Now, few words regarding the Robson 10 group classification. What we are doing in our government medical colleges in the government of West Bengal in Calcutta, every cesarean section has now been audited. Though it is not a framework of 10 group classification of this Robson criteria, the advantage of Robson criteria, it is not actually the classification of cesarean section. It is basically the classification of the delivery also. Here the primigravida, multigravida, spontaneous onset, or induction, or post-cesarean, everything is included. Now, what is our observation in doing in a government medical college in the government cesarean section audited, as well as the few corporate hospital cesarean section? If we really want to do the reduction of the cesarean section or judicially use of cesarean section, how it is being helpful, Robson criteria. Number thing, if we look at the cesarean section in the categorization, if you look at the government sector, the cesarean section category 5 is the highest. So it is the post-cesarean pregnancy. But in the private sector, the same demographic population, almost same demographic in Calcutta, the 10 group 10, that means the prematurity. So definitely there is a, other than the direct indications of cesarean section, definitely there is some preference of the surgeons and patients also have a cesarean section. Second thing, In a government sector, the category 1 is more important than category 2. There is all the cesarean section have the spontaneous patient in laboring mother cesarean section. But if you same thing in the private sector, you can find there is a category of 3, that is the patient is not in the actually multiple, whether it is category 2 and category 4, that is patient is not in labor. And the other thing is that there is a wide variation of cesarean section rate in government or private sector. In West Bengal, the cesarean section rate is almost 47, 48%, whereas the private sector is more than around 80%. So all these things have to come into account then how we reduce the cesarean section. Whether the cesarean section is also another factor is we really want to reduce the cesarean section, because if we go for the maternal health and also ultimately the maternal MMR, maternal death, you can go for every maternal death is now under surveillance, that is the maternal death review and surveillance. In a government sector, particularly when we are auditing this maternal death, the most of the time that there is more than above 60% patient have a direct association of cesarean section. That patient, maybe cesarean section is not a cause, but the interesting finding is the maternal death, there is a 65% above the cesarean section. You agree that the cesarean patient has a higher risk factor because they have undergone some maternal risks like eclampsia, pre-eclampsia, or post-cesarean or placenta accreta. That we are, so everything have to look into account, and that is why if you we have to categorize the clinical characteristics of the patient, because over the years the elective cesarean section or the emergency cesarean section or category 1, 2, 3 we have not been able to reduce this. But if you catch up that hospital, which category of patient is going more cesarean section, that in the government hospital, if you look after the post cesarean pregnancy, so primary cesarean section must be reduced. But the same thing in the private sector, you have to reduce the prematurity, cesarean section of prematurity and cesarean section in the non-laboring mother. Then you have maybe or will be successful to reduction of the cesarean section. Thank you, Dr. Queen, once again for elaborating all these things. I am just adding few words, our direct observation, practical observation on auditing the cesarean section from our hospital point of view and government point of view. Thank you, everybody. Thank you once again for inviting me. Yes.
Thank you, sir. Thank you, Dr. Vijay. Thank you.
Thank you, sir. I thank our chairpersons, Dr. Neelam, Dr. Rita Jha, and Dr. Ram Prasad Desar, and the speaker, Dr. Queen Aditya. Moving to the second session. The topic is Caesarean section technique, and the speaker is our organizer, Dr. Sadhana Gupta. Introducing the chairpersons, Dr. Avinash Chandra Rai. He is the president of Bengal Obs-Gynae Society, visiting gynecologist and laparoscopic surgeon of Amri, Bellevue, and Charnock Hospital, Kolkata. Senior vice president, NRS Medical College, School and College, ex-student association, winner of Foxy Best Paper Award on Maternal Child Health Care, winner of first prize ICARM 97, several publications in National Journal, and author of 3 highly popular books on obstetrics, gynecology, and infertility, written in Bengali for public awareness. Dr. Bishwajyoti Guho. He is the secretary of Bengal Obs and Gynae Society, senior consultant obstetrician gynecologist, Amri Hospital, Mukundapur, and Bhagirathi Neotia Hospital and Children Center, Newtown. Fellow representative of International Representative Committee, RCOG, India East. Member Perinatology Committee, Foxy, Vice President, ISOPAP, Kolkata Chapter, peer reviewer of Jogi. Dr. Pramila Modi. She is a consultant in Modi Nursing Home, Patna, Vice Chairperson of 57th AICOG 2024, Patna, and Scientific Chair, past President, Patna Obs-Gynae Society, ISOPAC past contributor and executive member, past chairperson in Akhil Bharatiya Marwadi Sammelan, lots of publications to her credit, several chapters in Foxy books and other textbooks, various awards like Ethicon Traveling Fellowship Foxy Award, Dr. Jagadishwari Mishra Award, and Lifetime Achievement Award by Patna Obs and Gynae Society. I welcome all the chairpersons. May I request Dr. Avinash Chandra Rai to introduce our speaker, Dr. Sadhana Gupta.
Namaskar and good evening everybody from Kolkata, our beloved city and city of joy. At the onset, as the president of Bengal Obstetric and Gynae Society, it's my great pleasure to convey my best wishes to dear Dr. Sadhana Gupta Madam for our Foxy presidential election. You all know that this year we are having very tough contest in the Foxy presidential election in e-voting system. We have 5 candidates for Foxy presidential election. Now, coming back to the academics, we all know that Caesarean section is the most commonly performed major operation in the world and most commonly done by the junior doctors. Now it is the session in the second session and Caesarean section workshop. It's my great pleasure to invite Dr. Sadhana Gupta to deliver her talk on Caesarean section techniques, for which we all are eagerly waiting. Dr. Gupta, please. Platform is yours.
Thank you, sir. Thank you, Dr. Avinash. Thank you for your kind words. And yes, no pressure, no diamonds. So that is the God's way to creating diamond, because God exposes us to pressure, and more so with the hardworking people. He puts different situations so that we come out with the like a more strength and more glitter. So thank you. And once again, my hearty thanks to Dr. Avinash, Dr. Vishwajit, Dr. Meena, and Dr. Amita for all the coordination. And I will be sharing a standard technique what Dr. Manjugita Mishra. Everybody says a worry about the all complication of cesarean section. And in my talk, I will not go to the details of the technique to August gathering, but where we need a fine tuning and the final tuning, that is the need of the hour. So let me share my screen for it. And the topic which actually, it was some way like around a year ago, then this is the topic which actually I'm merging that what is scar complication, what is scar niche, and how it create bad for the placenta accreta spectrum in a large range, and can we do something to prevent it. So a brilliant presentation by Dr. Queen on the incidence and a lot of issue. Actually, it is so easy to say that we can really reduce cesarean section. The situation with the 100% expectation, medico-social issue, the issues of the one-person hospital, and the not having like that much of the people who are around us to look after, and still the issue of the trained nursing staff whom we can believe. So a lot of issues are there in our country, and we have to look into it. And the standardization of cesarean section technique and a good teaching, because today we are having like a company of a wonderful teachers. So the good teaching and the training, that is important. So here I present and seek everybody's blessings and good wishes and full-hearted voting and support for my candidature, because that will endorse the value of hard and selfless work in our federation. A great thanks have been we have a wonderful memories of AICOG and the conferences, what I say, Vice President Conference, Foxconn. So it has been a repeated visit, and we grow with a lot of warmth and the friendship all over. We meet wonderful people which enrich your life. We learn and we share and we enjoy. So I bring greeting the Patna and the all place. It is the Kolkata and the Patna. That is the place of the our ancient wisdom, where the Buddha explored, and we have Nalanda, and what they have been the something but internationally reckoned for the education, which was not technical, which was not for earning livelihood, but attaining the highest perfection of the soul and the human mind. So this is what Buddha says: we can never obtain peace in the outer world until we make peace with ourselves. So we have to observe the world, what is happening around us, and that makes that what we do during our minute-to-minute, day-to-day profession. So cesarean section, is always unique surgery involving two lives, done for not for disease, but for the physiological process. And it actually bypass one of the very difficult journey in human being, that is the birth. Most commonly performed, around 30 million unit born worldwide, and it is historically in the backdrop of women empowerment. So we have come from the time for the last measurement, last done we can do for saving mothers, to the huge demand for getting cesarean section on the request. We are having all the backlash, all the bricks and all the bouquets. But in today's scenario, what is the WHO as well as FOXI says very strongly that every effort should be made that the woman has a good, pleasant, positive experience of vaginal delivery, and every woman have at the same time access to quality cesarean section and the safe cesarean section. So here we are. Why we are worried for the high rate of cesarean section, and with Dr. Ram Prasad, they emphasize that there is a lot of difference between public and the private institution. So many things which are undercurrent doing, but what we are worried, it is economic cost, because finally it is us, like our people, government, anybody, insurance company, anybody will pay, but there is no free lunch like thing in the world. Higher maternal morbidity and mortality, what Dr. Madam Manju Geeta Mishra says, we have, and we can have more perinatal morbidity as well because of iatrogenic prematurity and all the dreaded complication of the spectrum of the perpetual spectrum, which we actually don't know what are the exact diagnostic modalities and what are management modalities. And globally, it has been the emerging cause of the maternal criticality. So with this brilliant presentation by Queen, the cesarean section should always be just cesarean section. And this thing I have learned actually from the Dr. Sukanto. So this is something what we listen from our senior, we actually imbibe, because these are the golden words. These are not old paper, these are the new papers which shows the lot of complication after cesarean section, and we must have the very close eye that what we are happening in our institution. So I will go for the immediate scar complication, which can be infection related. And now when we have a lot of obesity, GDM with us, and a difficult, like what we can say, the obese patient, diabetic patient, so a medical comorbidity that makes that the cesarean section can be the site of surgical site infection. And we know all the thing what we can do, that wound swab, sometime good antibiotic, sometime the surgical excision. But what I want to do in a section to prevent this complication, which is the prophylactic intravenous antibiotic, and it should be given. The more important is the 30 to 60 minutes before skin incision, neither before, like 2 hours before, not after delivery of the baby. And it can be like single dose, max 24 hours. But if there are any high risk factor, you can definitely add for the 5 days. So sometimes we are really carried away the thing, and we have to individualize. Like it is not only always we give the single shot. Some patient really need the 5 days antibiotic, second generation cephalosporin and the NP-gentametrozole. Nothing can escape from the universal safety precaution. Universal sepsis precaution, not only our cesarean section operation theater, but also in our labor room. Postpartum uterine dehiscence comes to you as a silent, unexplained cause for the refractory postpartum hemorrhage. So many, we have a few groups where we do that case-to-case discussion. So many times it is a refractory, it is unexplained. I wish to give to this entity that the postpartum uterine dehiscence can come as early as 10 days to 2 or 3 months after cesarean section. If you find any presence of bladder flap hematoma, pelvic hematoma, presence of gas which is going into endometrium, think that it can be your diagnosis. And this is the weak and unhealed scar, and the less optimum healed scar gives you the like a cesarean scar defect, which can lead to the this postpartum uterine dehiscence. We are doing a lot of color Doppler, and everybody is like, many times the people after surgery, after delivery, they come that it is a AV malformation. I just want to have your attention for this, that not only increased vascularity is the AV malformation, or it is pseudoaneurysm. It has got a different pattern in yin yang. And if you see, there is a turbulent flow which is actually circulating in the clockwise and the anti-clockwise. Sahiti, kindly unmute. I think some person is one is unmuted, muted. So please kindly mute. So this is the thing. And when we have the unstable situation in the pseudoaneurysm on the postpartum uterine dehiscence, many times the hysterectomy is the only choice. But if the patient is stable, then you can go for the interventional radiology, and if it is available. So that weak scar can cause the bed for the all placenta accreta spectrum, one of the biggest challenge. And this Caesarean scar niche, which I want to bring everybody's attention for this, that if you see after 12 weeks that irregular hypoechoic triangular oval outward or inward extrusion, be careful that it can be the bed for all the things, scar, pregnancy, and the placenta accreta spectrum. Not going into the, kindly Sahiti, please unmute something. I think Sahiti, please look into it. So genetics, deficiency of deciduous, a lot of things about it, but I will just say that bring your attention to the entity of the scar niche, which have got the name for the Smooth Caesarean scar defect. You can identify with the transvaginal sonography, sonohistography. If you add some time in an inconclusive TVS, it adds to your diagnosis. More number of cesarean section, more chances that there can be scar niche. So scar niche is the bed. It gives birth to the placenta accreta spectrum, and the risk factor can be the surgery related when we are doing the first or the cesarean section when she was having pregnancy, and the patient related. So this is the picture irregular. If you are seeing a normal cesarean scar, it is just a small hypoindented spot. What makes the risk factor for cesarean scar defect? Adhesion. So adhesion gives a, like it is adhesion and it is a counter current force. So there is no less blood supply to wound and the less healing. Retroflex uterus. Patient factor, more number of cesarean, high BMI, GDM, as well as the genetic predisposition. What I wish to emphasize, very, very important, that the timing of cesarean section is a very important factor in the wound healing. If we do cesarean section in advanced labor, or we do cesarean section much before the time, like in elective cesarean section, all of us, family, we are all comfortable around 37 weeks, then we don't put the incision at the right place, and it results into the suboptimal healing. So what are the risk factors for the cesarean scar defect? That is the maternal age more than 35 years, more number of cesarean section, more number of induced abortion. And I'm really afraid that the medical abortion might add to it in some way. We actually don't know, and we must be careful about it. And Sahiti, please mute. There is something wrong. Sahiti, please, if you are here. And the place of cesarean section, that is very important, because when the government is actually pushing us that do cesarean section by MBBS student, by PhD, by CHC, this wonderful paper at the China says very clearly that the cesarean section and rural community hospital is the independent factor for cesarean scar pregnancy. So that highlights that why the expertise, experience, right technique, and the right timing of cesarean section is so very important. A few modifiable risk factors are surgical related. So if we give incision close to internal os, or we exclude the endometrium during repair, and the single layer closure, these are the issues which have been found related to the scar niche as well as the all placenta accreta spectrum, right from the scar pregnancy to in the early first trimester to the full-fledged pass. It can present to you in gynae clinic as well, maybe asymptomatic, and the abnormal uterine bleeding is very important. She is having brown discharge and you are putting on many times. So why there? Because there is a niche. So the menstrual blood flow is obstructed and then it is slowly released, which cause the painful abnormal uterine bleeding. So prolonged bleeding, intermittent spotting, chronic pelvic pain, you must consider it is not the diagnosis that it is always PID or it is always endometriosis. It can be scar niche and the mid-cycle fluid accumulation. They can come to you as a secondary infertility if we do IVF, not able to put the embryo at the right place, bladder dysfunction and scar abscess. So it can present in the immediate postpartum period, it can present to you as a gynae, it can present to you as an infertility clinic, and it can present to you as a chronic pelvic pain and the abnormal uterine bleeding. So these are the serious sequel and scar niche, because we are having a lot of cesarean section. It is very much around us. A beautiful paper by our own Indranil Datta, who says actually what we face as a clinician, it is a sudden torrential bleeding when the patient had taken medical abortion, even sometime week or month before, or we do the suction evacuation for incomplete abortion or even simple MTP, and we suddenly face the life-threatening hemorrhage. It is an experience of our day-to-day, and identification of scar niche in the pre-pregnancy interval can actually guide us that this patient can have the risk of all scar complication. So two things: first you identify, and second is the residual myometrial thickness. How much myometrium is there? That less the myometrium, there are more chances to having the scar defect. It can go outward, inward, and it can have all the features. TVS, sonosalpingography is the thing, and this is especially for the teaching institute. I think we should take few research paper, good research paper, and already we have very good paper from our own, like AIMS, Dr. Vidushi has worked, and Dr. Alka Kriplani have given, like she has gradually collecting a lot of case and a very, very big scar niche like a bag, which she is like operating and gives a very good preview of the video for these things. So symptomatic patient need management, sometimes only COC, and when there is a secondary infertility, then we need the surgical treatment, or when there is a refractory AUB, that we can, if it is low down, you can give the hysteroscopic resection, sometimes laparoscopically. Usually it is to be laparoscopic or maybe the open, because you have to dissect that thing and then repair the thing. So for bleeding, subfertility, transabdominal approach, laparoscopic, but important thing, it is so easy to say. What we say in a very practical thing, what actually we have to face the world, actually what we are having. Even in the Western world, they are concerned about the availability of the professional and the technical expertise, about the issue, about the like that infrastructure, which a lot of things. It is so easy to say robotic surgery, but where we are, it is costing 1 to 2 lakh extra. So we have to, as a person, what we have to be really looking forward. When the very developed world have got the question mark, then we should always consider what is the learning curve, where are the centers, and that is the something. So primary prevention is the minimizing section rate, and the secondary prevention is the good standard technique. So timing of cesarean section, a very right decision, like around 8 to 10 years ago, patient always used to say to me, we will come when, even for the elective cesarean, when there will be pain. So it actually, what was the wisdom in that? It was close to term. We get a very well-formed lower uterine segment, less difficulty in delivery of the baby. But now that nobody wants to take risk, they say, no, it is 37, so it's okay. I don't want to come in tonight. So a mindset change from the people to the doctor is very important, because too early or too late, then the level of uterine incision will not be that good. And this is what we say, this wonderful paper, position and integrity of uterine scar is determined by degree of cervical dilatation at time of cesarean section. So this is very important. And in our discharge ticket, when sometimes we really, like, people don't even put the indication for cesarean section, which is so very important with the so many audit which is coming to us for the cesarean scar. We must also mention that the cesarean section was done at what time. It is 37, 38, 40, or at the onset of labor. So this is something very, very important point I want to say, and a good research paper. And coming to standardization of the cesarean section technique. So this is a picture with the Atul Gawande. And when we exchanged the book at FIGO and the Brazil, when he was with us, and I think that the like Patna and Bengal, they are the ardent reader. And once upon a time when I used to read, really, once upon a time I had this like dream of becoming a writer and not the too much. So I got the maximum like a postcard or something from the like Patna, and the reason because the Bengal has been the ardent reader, which is the place of reader, Calcutta, Patna. So I think all teachers, we young generation should hook to it. The fiction which has been written by the doctor, because it actually helps to analyze our brain as a doctor, as a surgeon, how we respond in emergency, what makes us a good doctor, what makes us a brilliant surgeon. Now, coming to standardization of the cesarean section technique, which is an important public health issue is now we are having what it is e-classic for clinicians. So why I'm like really looking that we cannot go away from our roots and the foundation of the basic classical teaching, because what we are having forest for the tree, and everybody is doing cesarean section in their own way. So there are a lot of argument now, and a strong argument that there must be the standardized cesarean section technique. So all resident, all trainee have got idea that it is a standard technique and the flexible whenever it is needed or whenever it is required. And they have strengthened recommendation for all studying the research paper and for the new versus surgical. So everybody is fair that no, I always do the single layer. I never exteriorize the uterus. And what are the issues which cause the cesarean scar defect as well as the suboptimal healing. So these are the few images right from my own book. What are the standard surgical technique, and few technique which has been recommended in the paper: transverse incision 2 to 3 centimeter above pubic symphysis, sharp subcutaneous fascia dissection, then blunt and the omission of superior inferior fascia dissection, blunt peritoneal entry, omit bladder flap development to be given, but some again there is a question mark that the few new people are really saying that omit bladder flap development, and uterine incision sharp 2 to 3 centimeter, transverse uterine incision, lower segment blunt entry, fallout colloid extension. No placental removal manually, no intrauterine wiping, no routine cervical dilatation. Uterine acceleration is actually recommended because of its safety and because of the many things what we can like diagnose with the uterine acceleration, like a posterior wall hematoma, like a adnexal mass, and we can massage the uterus. And of course, for any additional measure like selective devascularization and the compression suture, we have to have. Double layer non-locking suture with delayed observable suture is the most important recommendation. No irrigation. We omit visceral peritoneal closure, but the parietal peritoneum closure is recommended because non-closure of parietal peritoneum is like add to the adhesion, and that adhesion cause the suboptimal blood supply. Omit rectal vessel approximation, omit routine glove change, rectus sheath continuous closure, subcutaneous tissue either staple subcuticular, and if it is more than 2 to 4 centimeter, then we do the subcutaneous tissue repair. So uterine externalization, it is not added like to the time, no additional advantage for the in situ repair, but sometimes it can be the more safe. So 2-layer non-locking suture is the thing which is emphasized by most of the studies. It gives you the most like thick residual myometrial thickness, and the single layer closure gives you the less residual myometrial thickness. So prevalence of seal is in the rise, and it is more associated with the single layer. So these are all studies which actually emphasize that what should be the like a level of incision, timing of incision. Include decidua, that is recommended because it gives better approximation, and avoid locking suture, very tight second layer suture, which can lead to ischemic necrosis. So the very tight suturing is result into the poor heal scar, which present as a niche formation. Basic surgical principle we have to go give to the all generations of the surgeon and the obstetrician gynecologist, that is no excessive tissue handling, no very tight suture, inadequate hemostasis. We have to be very, very meticulous. And the few things have been proposed, like it is a Misglab modification technique, which says neither Phanestold nor Joan Cohen. You just follow the skin crease and go the length of the incision as per the baby's head size, and then closure of the uterus is done using two container suture, which are then knotted together, which result in a short time and the double layer closure. So these are the few pictures which says that it gives you a very good, strong uterine wound that is healed. And this is another proposition. It is not a standardized technique. I'm just putting that these techniques have been evolved in their attempt to give a very good uterine thickness and a very good residual myometrial thickness. It shows that it is a double layer, but it is in a two loop. So cephalate caudal to cephalate, caudal to cephalate, and you tie then in a one go. It is having the double layer suturing with a very strong biometric approximation. So, but surgeons believe in curious egalitarianism. We believe in practice, not talent. So finally, the cesarean scar niche is a give us a new understanding for understanding all the spectrum of the placenta accreta, right from the post-cesarean scar dehiscence to the scar niche to the scar pregnancy to full-fledged placenta accreta spectrum. We have to be aware of it, good diagnosis, and most important, the prevention by the reducing cesarean section rate to the just cesarean section rate, and a very good surgical technique, and a very important thing that the good training, like teachers used to, it is we have to train our young OB-GYNs so that they know what is the standard, what is the flexibility, and that will reduce, despite a little rise in cesarean section, which is bound to be there, we will not have the backlash of all the complication of the cesarean scar. So the world has become too complex for simple answer, as the people believe and show, but actually it is not. Living is simple as it is defined, as nature is simple and nature is grand. That's why the way our life are. So I seek again your full-hearted support for my forthcoming election as a Foxy presidential candidate. And thank you once again.
Thank you very much, Dr. Sadhana Gupta. Thank you very much for your very nice, elaborate talk. Learned a lot, and I must stress that, as you told, the standard technique. I told initially that lots of junior doctors are doing cesarean section throughout the world, maximum the junior doctor. If they follow the standard technique, post-operative complication, post-operative problem, which much less, and what you stress very nicely. For your clear message, I thank you once again very much, because it is a operation or in our day-to-day practice, everybody, we do the cesarean section. So it will be very good for the viewers who are heard your see your talk. Thank you very much once again, Dr. Gupta.
Thank you, sir. May I request Dr. Pramila Modi, madam, for her expert advice and comments. Pramila Modi, madam, please unmute, madam.
Madam, unmute yourself. Madam, unmute. Madam is calling something.
Can we have comments from Dr. Vishwajit Guha, sir?
Madam will come. She has asked something, someone.
Yeah.
Unmute.
Yes, we'll again invite her back. Dr. Vishwajit Guha.
You also muted, Dr. Guha. You're muted.
Dr. Guha.
Thank you very much, Dr. Mausumi, for giving me this opportunity to be here today. And then thanks to Dr. Sadhana Gupta for inviting me here. I think Dr. Sadhana Gupta has touched on the very important aspects of cesarean section, which is, giving a incision on the cesarean section and how to actually mend the cesarean sections, incisions. And it's a fact that we are facing more of scar adhesions now, more of scar ectopics now, because the rates of cesarean section has increased tremendously in the last few years, forcing our government to have this audit now going on in West Bengal. So taking on Dr. Ramprasad Dey's line that in government sectors, the cesarean sections are really not low, but it's much lower than the private sector. I work in a corporate hospital, and I believe you in me, in my hospital, the cesarean section rate is almost as high as 90%. And it is because of some of the mothers coming and requesting us to do the cesarean section. And also about the scars, really, we are getting a lot of scar ectopics nowadays because of the first cesarean section. And that is what we have to prevent and we have to go through. So that is, so thank you very much for inviting me. And I will just end my talk to my deliberation today with one of Atul Gawande's favorite thing, that because Dr. Sadhana Gupta mentioned Atul Gawande, I will just end it by saying that better is possible. It does not take genius, it takes diligence, it takes moral clarity, it takes ingenuity, and above all, it takes a willingness to try. So whatever we do, if we try hard, we are definitely, and if we do the right thing during the cesarean section, if we teach our trainees the better way, in a better way to do the cesarean sections, lots of complications can be avoided. So thank you very much again. And I hand over my virtual dais to Dr. Mausumi, please.
Yeah, Mausumi, I'm here. Can you hear?
Yes, madam, please.
Yeah. So, सोचा था क्या क्या हो गया, आज मैं ये बोलना चाहती हूँ. हम लोग 3 chairpersons for one famous speaker, Avinash and Vishwajit, we decided who will do what. So everything went otherwise, everything was toppled. Anyway, I cannot resist myself by congratulating the zeal of taking such a scientific event. See, everybody is doing cesarean section once OBGYN person has started doing practice, or not even doing practice, but working in some hospital, government hospital. C-section for an obstetrician is the beginning, and it will remain throughout our lives. What I just want to, before that I forget, I wish all the best from all of us, from Bengal and Bihar, everyone. We pray to the Almighty that Madam Sadhana Gupta wins for the presidentship. That's what is the first thing that I want to say. Secondly, I had written quite a lot, but the time has gone. So the thing is about the topic. I am remembering of one case who was put up for a C-section. Rather, we knew that she was having a placenta accreta. We knew it. So I said, this is not the right place, my nursing home, to handle. This is very important. Where to operate? If you come to know by ultrasonography that it's a case of accreta, percreta, whatever, which is the right place to take up. It's nothing that I can't do. I can do. But what about the other facilities? So I decided to take help of Dr. Manjugita Mishra. We knew that it was accreta, and the sonologist reported that part of the placenta was inside the bladder. I had never seen. Anybody you have seen that the placental piece has entered the bladder? Anybody?
Yes.
Okay, if anybody has seen, that's good. But then that was the first time that accreta I have seen many times, but then going inside the bladder and the presenting symptom at the term when she was to be operated, she complained 2 days before that hematuria ho raha hai. तो मेरा कान खड़ा हुआ, हेमेच्यूरिया हो रहा है, क्या हुआ, इतना दिन तो कुछ यूटीआई नहीं था. फिर से यूएस कराए तो उसमें पर. Madam, I tell you really the amount of blood loss that she had during operation. So there was a team of a urologist who is going to be of help. And Dr. Manjugita Mishra somehow delivered the baby out safely. So one part was over. But what about closure of the bladder and then the placenta still getting adherent and all. Such things are really so, nightmare. And particularly if you do not know beforehand, just imagine the situation. She took long time to recover, many bottles of blood, but she recovered. And I'm so happy about it. Second case I wanted to tell that we are talking about even cesarean section means right from the scar, as rightly Madam Gupta has told, Sadhana Gupta has told. It is not only the uterine scar, it is the skin scar also. We are now seeing the scar which is adherent there. Of course, that is when we open. Otherwise, scar endometriosis is not that rare, we are seeing. And the third thing is, just recently, few days back, there was a lady who had 3 cesarean sections elsewhere, and she came with the written report that there is a sinus over the scar. Sinus that the skin has got is usually dealt by the general surgeons. We usually do not do it unless we are well trained in taking care of the sinus. So my daughter-in-law is much younger to me. She's enthusiastic. हम ही लोग करते हैं. हम बोले ठीक है, छोटा है, कर लेते हैं. देखो सर्जरी में तो किया था बहुत. तो we got a sinogram. मैंने कहा नहीं, मेथोडिकल होना है. तो साइनोग्राम में निकला साइनस है. It is much above the uterus, and it was not intra-abdominal at all. It was only the skin and below the structures. We did it. मैं भगवान का नाम लेते लेते बोली थी ठीक है, ये किया था, करते कर दिया. और देखिए वो ठीक हो गई. लेकिन मुझे हर रोज डर लगता है, उसका फोन आता है कि फिर कुछ चू तो नहीं रहा है, something is coming out or what happening. Till now, it's that probably 3 weeks that we have done it. So she is okay. Such things are unexpected that happen after the cesarean section, 3 weeks after. These are the 2 points I would have. Now the thing is about the isthmus seal. This is the question that I would like to hear from Dr. Gupta, Sadhana Gupta. When isthmus seal is diagnosed antenatally, what should be the action?
What I say that if it is asymptomatic, we just like nothing to do. If it is a presenting complaint is abnormal uterine bleeding, then the COC is okay. But if she gets pregnant, then we have to be very careful that this isthmus seal was there. Then if she gets pregnant, then we have to be very careful in excluding the scar pregnancy, like not prescribing any medical abortion drug. Very careful that the patient is having it. She is having pregnancy at the right time. So the important thing for recognition of this entity that we and the family mother is prepared that she is having some issue, that is the scar niche, and it can also present like a early scar dehiscence if it is not placenta accreta. So the thing is that if we recognize that it is a scar niche, if gynae complaint, they have to be dealt with. Otherwise, if there is a very resistant abnormal uterine bleeding, then we say that it is a surgical correction, which we can do laparoscopically, where we actually excise the niche and repair the thing. Hysteroscopically, what we do, it is only if you are approachable, you can approach from below, and they only just excise, they just coagulate. So her symptoms are relieved. So it is not a very optimal treatment, though it can be done. So this is according to the symptom wise, and the important thing is the readiness, and we have to be careful that this patient can have. What we say when she is becoming pregnant, but if we are having the knowledge that this patient is having the scar defect, though she may be asymptomatic, but if she gets pregnant, we will have a close watch that where is the pregnancy, and we might avoid the life-threatening complication. That is the knowledge of. It is not that every asymptomatic scar niche need to be treated. It is awareness only. Yes, it is abnormal. Yes, if it is a distressing symptom, secondary infertility, IVF failure, then this bladder abscess, and the chronic pelvic pain, then it is the thing that we consider that it should be treated surgically.
Yeah.
AUB, sometimes the COC is also effective because it reduces that menstrual blood, so it might be effective, but not LNG IUCD. So that is.
I would like to put my view about reducing, as we always talk, reducing the CS rate. We all want, but sometimes I belong to a public sector. I mean, a private sector, not public, private sector, my own nursing home. There is a lot of difference in the documentation, which is done properly in the private sector. It is done. Otherwise, I'm sorry to say, it's not much properly written. That is the whole difference. And secondly, when we operate or decide to operate in private sector, it is always said, प्रमिला मोदी के यहाँ जाने से तो सिजेरियन हो ही जाता है. कोई नहीं चाहेगा सिजेरियन करना और कोई नहीं चाहेगा सिजेरियन करवाना. But situation compels us to do cesarean section. And they think, last few days back, one lady asked me, कितना cesarean तक कर सकते हैं मैडम? तो मैंने, आपको कितना cesarean चाहिए? आपका कितना बार हुआ है? तो बोली 4 बार हो चुका है. मैंने कहा, मैं नहीं कभी भी कहूंगी कि आपको और
Actually, Madam, what you rightly says that yes, there is a issue that we have to be audited and everything will come, but we need a lot of like a good infrastructure for a good vaginal delivery. That is very important. And what I emphasize that it is not only the number, standardization of technique, good aseptic precaution, our basic thing, that is the access to quality care, and that standardized training, like every house surgeons, MBBS doctor, if they are doing, they must do in a right way. So I was emphasizing on the indication, but I also emphasize that if we do, many people say, even sometimes I say, my cesarean doesn't get the placenta accreta, because few people are confident that they are doing in a right way. So something we have to look into that matter also. So my emphasis was on the timing, technique, quality, and the closer and the all technique for the cesarean section. That will also reduce the placenta accreta. So thank you very much, madam. Thank you very much.
So thank you, our chairpersons, Dr. Rai, Dr. Pramila Modi, madam, and Dr. Guho. So moving to the third session on post-operative care and complications. The speaker is Dr. Richa Jha. May I introduce our chairpersons? Dr. Amita Sinha. She is the secretary of Patna Obs and Gynae Society, communicator in ISOPAP, East Zone Coordinator in Practical Obstetric Committee, FOXY, recipient of FOXY Padma Bhushan Kamla Bhai Hospital Award, and special interest in preventive oncology and high-risk pregnancy. Dr. Sukanto Mishra, he is the professor and head of Vivekananda Institute of Medical Sciences, Kolkata, president of Bengal Obs and Gynae Society 2015-16, founder, president of Bengal chapter of Society of Vaginal Surgeons of India, president of Kolkata chapter of ISOPAP, member of Penal and Ethical Committee, West Bengal chapter, PhD committee of West Bengal University of Health Sciences, peer reviewer, editor, faculty in conferences and examiner, and lots of publications to his credit. Then we have Dr. Hemali Sinha as chairperson. She is the professor and head, All India Institute of Medical Sciences, Patna, with professional interest in maternal fetal medicine.
Thank you, madam. I think we should continue with the session. Thank you so much.
Yes, ma'am. It's my honor to introduce you. Yes.
Okay, yeah.
So may I request Dr. Amita Sinha to introduce our speaker.
Yes. Thank you, Dr. Mausami, for the nice introduction. And I also want to thank Dr. Sadhana Gupta, madam, for giving me this opportunity. Now this third session starts, and after listening so learned and senior consultants, now it's time to listen a very young, dynamic speaker, Dr. Richa Jha. Dr. Richa is assistant professor at Department of OBGYN, Government Medical College, Purnia. She is co-chairperson of Endometriosis Committee, POX, Master Trainer of Dakshita Program of Government of India. She has received Dr. Manju Geeta Mishra Gold Medal Award for Best Paper Presentation in Boxcon 2018. She has also received first prize for paper presentation in FOXY, Vice President Conference LaborCon. She has published papers in peer-reviewed national and international journals, completed ICOG certified course in OBGY, obstetric critical care, and she has a special interest in high-risk pregnancy and critical care in obstetrics. So I welcome Dr. Richa Jha, and I request
we
Dr.
can,
Mosmi.
yes, madam. Can I request Dr. Sukanto Mishra, sir, to introduce the topic?
Namaskar from Kolkata. Good evening to the organizing team for including me and inviting me to be a part of this wonderful. Am I audible, by the way?
Yes, sir, you're audible.
Yes, sir.
Fantastic. Fantastic. My special thanks goes to Dr. Sadhana Gupta. Sadhana ji, the committed lady with a lot of conviction, having inclination towards academics, which is obvious looking at the pearls of wisdom she's publishing on a regular basis. And I think nearly 50 publications have already been done. And we are basically silent watcher from the distance. We may not have responded, but kudos to her. Coming to the topic proper, I recollect one study in 2009, Institute of Medicine had said that most of the complications occur following some sort of intervention. And any operation with an intervention. Caesarean section nowadays, by now we all know that the incidence is increasing, despite some of the restricted criteria trying to reduce or restrict the number of Caesarean sections suggested by different world bodies. Even then, there are very high incidence of Caesarean section, maybe higher in public sector. But the factors are many. What is important is that even in primary cases, primary gravida cases, primary Caesarean sections are also becoming very high. Coming to the complications, whenever there is operations, there are complications. Complications are inevitable. I would quote Dr. Atul Gawande. Dr. Sadhanaji has right now mentioned his name. He has published a book called Checklist. Whenever we think of any postoperative care and management, we should consider a checklist. That's extremely important. We must appreciate the fact that the complications that occur could be due to patient factors, could be due to surgery factors. Right now, we need to know that some of the morbidities are present even before the lady is pregnant and were not taken care of. Some of the morbidities develop during pregnancy, whether may be diagnosed and treated, may not be diagnosed and treated. But the most important factors that we can take care of and we can reduce it is during surgery. Dr. Sadhana has already highlighted the standardized technique. Unfortunately, as of now, we do not have any technique of our own. I mean, we have our own, but we do not follow any standardized technique based on strong evidences that this is probably the best technique. Because biologically, each individual is different, complications are different, and for that we need to have very large multicentric trial and accumulation of data so that we can have certain important observations to dictate what should be called the standardized technique. The complications, the disastrous complications are mortality. What I can say that mortality can occur, the patient can die as early as 4 to 6 hours following delivery. So we need to follow the checklist. We need to take care of the lady immediately thereafter. And the purpose of these postoperative care is not only to give physical and emotional relief to the patient, to provide analgesia, but also to identify certain complications. Those are not only imminent, but also can develop even later on. Some of the delayed complications, particularly the scar-related complications, are already highlighted by Dr. Sadhana Gupta. Right now, we are quite aware of the fact that the Caesarean section incidence is pretty high in private hospitals. But I'm really interested to know whether the complications in a government hospital and private hospitals are comparable or not. Is there any difference? Because right now, Dr. Modi had suggested the documentation part in private hospitals are much better than government hospitals. That is one interesting thing which I am interested to know. Another interesting thing is that the characteristics of the surgeons and the nature of complications and the incidence of complications, the magnitude of the complication. That is another area that needs to be discussed and researched. I echo with Dr. Sadhana regarding the standardized technique to be followed to reduce each and every complications of cesarean section, and of course the reduction in cesarean section altogether. So without further wasting time, may I request Dr. Richa Jha to prepare with her presentation, and please listen to her. Thank you very much.
Thank you, sir. It is indeed my pleasure to speak or to get an opportunity to speak in front of the esteemed faculty members present over here. At the very outset, I would like to thank Sadhana Gupta ma'am for choosing such an interesting topic and an important one too, which we always practice and we do in our day-to-day lives. I would express my sincere gratitude to the chairperson and respected chairpersons for letting me speak on this important topic. So let me just share my screen. Is it visible?
Yes, yes, visible.
Okay, so we have had an elaborate session on the indications of cesarean section and the technique of cesarean section. Now, I would like to carry on the talk further by discussing the post-operative care and complications of cesarean section. So we know that one of the Sustainable Development Goals of WHO, as proposed by the WHO, was to bring down the maternal mortality rate to 70 per 1 lakh births by the end of 2030. And India is doing its bit by bringing down the maternal mortality. At present, India's maternal mortality is 97 per 1 lakh births, and that of Bihar is 118, as per the 2022 data. But if we see properly, most of the maternal mortality is concentrated or centered around the intra and the immediate postpartum period. As can be seen from the following pie chart, around 69.5% of the mothers die in the intrapartum and the immediate postpartum period. Also, the maternal mortality has been estimated to be 4 times higher in cesarean sections than the vaginal deliveries. The cesarean sections account for the maximum cases of litigation nowadays. Therefore, awareness regarding the common as well as uncommon complications of cesarean section is always advisable. Now, my topic is divided into 2 parts. First of all, we'll talk about the post-operative management, and then we'll go on to the complications. So the pillars of the post-operative management of a cesarean section patient would be vital sign monitoring, fluid management, assessment of bleeding. It could be either abdominal bleeding or vaginal bleeding, pain management, infection prevention, and extending psychosocial support to the parturient, which is very, very important. Now, when we talk about the vital signs monitoring, it is extremely important and its importance cannot be undermined in any case. It should be a continuous one-to-one care, and monitoring should be carried out by an experienced staff or preferably a doctor for at least 12 hours. Every 15 minutes in the first hour, every 30 minutes in the second hour, and then repeated hourly. The signs to be monitored are very simple: pulse, blood pressure, urine output, saturation, respiratory rate, temperature, and consciousness level. And it should be preferably in the recovery room under the supervision of an anesthesiologist or an intensivist. We have to evaluate the fundal height, the uterine tone, presence of vaginal bleeding or incisional site bleeding. And minor complications like nausea and vomiting can be managed with the help of ondansetron or metoclopramide. Post-operative shivering also is a very important or a common complication where we have to keep the patient warm, give her warmed IV fluids or tramadol. This is a very important scoring system, which is the modified early obstetric warning system. And it is an objective way to assess the maternal condition, wherein each parameter has been given a range and a particular score has been assigned to it. If the score is within the normal range, that is, if it is 0, then the parameters need to be reassessed. But if the score goes anywhere between 1, 2, or 3, the paramedical staff or the ones who are taking care of the patient immediately need to inform the consultant or the intensive care unit. So this is very important, and a chart like this will help in assessment or early identification of the deteriorating maternal condition. And hence, I would recommend putting up such charts in our recovery rooms for in all the hospitals. Now coming to the fluid management. We all know that crystalloids are the fluid of choice in the post-operative period. The crystalloids, how much to be given? The NICE guidelines recommend 25 to 30 ml per kg body weight of fluids, and additionally, the electrolyte replacement of 1 millimole per kg per day. And they have to be given at the rate of 75 to 100 ml per hour till the bowel sound return. But again, this needs to be individualized according to the patient. Patients who have been in obstruction for a long period or who are dehydrated need to have a higher fluid replacement. And those who are having diseases like heart disease, severe anemia, preeclampsia, or renal disease need fluid restriction. An input-output chart must be maintained in all the cases because it gives a clear indication or an early indication regarding the deteriorating renal condition of the patient. The fluid responsiveness can be measured by a clinical test like the passive leg rising test, or we can do an ultrasound and measure the IVC diameter and collapsibility, which gives the amount of whether the patient needs further fluid management or whether fluid replacement is needed in seriously ill patients. Blood or blood component transfusion, there must be a justified indication for doing so, and careful monitoring while the transfusion is going on. Proper written consent must be taken before blood transfusion. For the pain management, the effect of pain after cesarean section can be tremendous to the mother and her family members. Therefore, multimodal analgesia has to be used. The most commonly used technique is the rectal suppository of diclofenac in combination of paracetamol 1 gram, which is very effective, and it is the one which is most frequently used. We can also use parenteral opioids like tramadol or morphine sulfate, but the enhanced recovery after surgery these days, the protocols which are laid down, they ask to minimalize the use of parenteral opioids for pain control. The patient can also be given the patient control epidural analgesia, which is a combination of ropivacaine along with fentanyl, can be used if the epidural catheter is in situ. The analgesia can be stepped down with the use of oral opioids or paracetamol, whichever is safer. A word of caution about the NSAIDs, we have to be avoided in cases of renal dysfunction and preferably in patients with preeclampsia. Now coming to infection prevention, for which the importance of proper hand washing can never be undermined. It has been estimated that around 60 to 70% of infection can be prevented by following the correct technique of hand washing, and therefore all the staff as well as the doctors need to be trained in proper hand washing techniques. The common organisms that infect the cesarean section or surgical site infection, which are responsible for it, are the group A and B streptococcus initially, followed by staphylococcus, enterococcus, anaerobes, and mycoplasma. So in order to prevent the infection, prophylaxis with either a first generation cephalosporin as per the ACOG guidelines in the dose of 1 gram cefazolin IV stat, given 30 to 60 minutes prior to the surgery or prior to the incision has been recommended. The dose can be increased to 2 gram if the patient is obese, that is having a BMI more than 30. But obviously the choice of antibiotics is purely dependent on the surgeon, and it also varies from place to place according to the local preference. Parenteral antibiotics, although further management is not required, but prolonged therapy may be required in certain cases like obstructed labor, PPROM, prolonged surgery, presence of postpartum hemorrhage, obese and diabetic patients. What are the general care that we can offer to the post-cesarean patients? First of all, let's talk about the diet. It should be a soft diet, and the patient should not be allowed to have spicy or junk food, and it can be allowed as soon as the bowel sounds return. Chewing gums, also called sham feeds, can be started 4 hours after the procedure, and it has been seen that these sham feeds or chewing gums, they promote gastric motility and have a prokinetic action and are preventive against paralytic ileus. The patient must be asked to have adequate fluid intake and maintain proper hydration with a daily intake of around 1500 to 2 liters of fluid. Encourage early ambulation, compression stockings for obese patients, and thromboprophylaxis, as has been advocated by the RCOG guidelines, that all cases of emergency cesarean sections do need thromboprophylaxis, which we will be discussing later, for prevention of DVT as well as the other thromboembolic events. Breathing exercises should be recommended to prevent atelectasis. The removal of urinary catheter. So ideally, we do not recommend insertion of catheter in each and every case. And if it has been inserted, it should be removed ideally after the surgery, but practically it is not possible so. And in cases of obstructed labor or in cases where we anticipate arrests, we do put a urinary catheter, and it should be removed as soon as the patient is mobile, unless there is a solid indication for keeping the catheter for a prolonged period of time. Wound care, the dressing should be changed 24 hours post-operatively, and no difference has been observed on wound healing with regard to the type of the dressing or with application of topical antibiotics, and hence it is not recommended routinely. The other most important thing that we need to do is proper care of the breast, early initiation of breastfeeding, which is very, very, very important, because as we know that colostrum is the first immunization of the baby. We need to extend psychological support to the mother, because these mothers are very prone to get into postpartum depression and psychosis. And it is only, it just requires 5 to 10 minutes of proper talking and letting her know how can she take care of herself as well as the baby. That does the job. We should counsel her for contraception, because it is a very sensitive period and patients are very readily going to accept our advice. The suture should be removed on the 6th or 7th post-operative day, depending on the case. But if there is a longitudinal incision, alternate stitch removal is first advocated, and then a total stitch removal. The timing of discharge is again individualized, and there is no fixed protocol as to when the patient should be discharged from the maternity ward. But before discharge, the danger signs must be explained to the mother, and advice regarding care of the baby as well as counseling for follow-up must be done. So this completes the entire panorama of postpartum care or postnatal care after cesarean section. Now, there has been so much talk about the enhanced recovery program that is advocated for early recovery of the patients after surgeries. So it was initially done for colorectal surgeries, but nowadays it has been recommended for routinely all the surgeries, wherein pre-operatively a prolonged period of fasting is not required. Carbohydrate loading is advocated. During the intraoperative period, normal fluid balance with a maintenance of normothermia, fast-acting anesthetics are all advocated. In the post-operative period, multimodal opioid-sparing analgesia is now recommended. Post-operative nausea and vomiting and ileus prophylaxis should be done. Perioperative nutrition should be taken care of. Early mobilization, no NG or nasogastric tubes should be inserted unless indicated, obviously. Early removal of catheter and drains, and daily care maps and discharge criteria has to be discussed. So this completes my section on the postnatal or postpartum care of the cesarean section patients. Now coming to the complications. So before I start dealing on the complications, I would like to emphasize that cesarean section is basically a teamwork. It is not only the obstetricians that are doing their job, but also the anesthesiologists that are present are also equally responsible, and the pediatricians as well. So unless and until each department works properly, the outcome of the cesarean section might be compromised. So we not only have to discuss the obstetric complications, but also the anesthesia-related complications, the medical complications that might arise, and the fetal complications of cesarean section have to be known. We will be discussing each one of them subsequently. Now, first of all, coming to obstetric complications, as Madam Sadhana Gupta has already said and talked a lot about the proper techniques of cesarean section, complications can be minimized by practicing all of them, but still postpartum hemorrhage tops the list of the postnatal complications and is still one of the major killers. we have to remember that the fit patients or the young fit patients who come to us for cesarean sections, they initially compensate for the loss, and vitals may remain stable for 12 to 18 hours following a blood loss, and around 2 to 3 liters of blood may be concealed in the abdominal cavity with only a slight increase in the girth. We also have to remember that it is very difficult to assess the girth of the abdomen post-operatively because of the increased pain. Again, atonic concealed PPH may also occur in the scenario of a tightly closed os. Sometimes bleeding occurs because of slippage of ligatures or broad ligament hematomas, which might have been missed at the time of closure, bleeding from the muscular layer, or omental bleed that might have happened during the process of adhesiolysis. All of them need to be taken care of. Sometimes there is development of a bladder flap hematoma, which is also very, very detrimental. So it is always recommended that one should spare 5 minutes extra to look and check properly before closing the abdomen, rather than having a lifetime of complications and a long medico-legal battle to fight. So in the post-operative ward, the deteriorating general condition of the patient and a shock index of more than 0.9, shock index is calculated as heart rate upon systolic blood pressure. If it is more than 9, then we need to stop, reassess, reassure the patient, and if needed, do not hesitate to perform or counsel for a relaparotomy. But before we do so, we have to arrange for blood products and be cautious of the coagulopathy, because most of the times it is not hypotension that is killing the patient, but hypofibrinogenemia, which is the killer. We have to act fast, but before doing so, proper communication and consent taking is very, very important to avoid litigation. We have to keep in mind that the earlier the bleeding presents, more are the chances of finding the culprit bleeder, because what happens after a certain period of time, we might just find a generalized ooze from the peritoneal cavity, and the actual bleeder is missing, or we are not able to localize it. That was about primary PPH. Now, secondary PPH is the incidence is around 1:365, and it is most commonly due to endometritis. Endometritis in turn can be because of PPROM, chorioamnionitis, prolonged labor, obstructed labor, and in handle patients. The patients present fever, rigor, foul-smelling lochial discharge, and a tender uterus. Secondary PPH again could be due to subinvolution of the placental site, leading to sloughing of the spiral arteries at the placental attachment site. The entire uterine scar dehiscence could be present, as Madam has already discussed. It could be because of retained products of conception, but it is very uncommon in cases of cesarean section, because we generally, it is under vision. We close the cavity under vision. Trophoblastic diseases also, and development of choriocarcinoma, we need to be very, very vigilant about this also, because sometimes the patient may present with irregular and prolonged bleeding after cesarean section. So carrying out a serum beta HCG must be done in such cases. And AV malformations and pseudoaneurysms is also a very common cause of secondary PPH. Now, what are the general measures that can be done? First of all, the routine measures, that is management of shock if the patient is presenting in a state of shock, fluid resuscitation, blood transfusion if necessary, and administration of uterotonics. For the treatment of endometritis, the drug of choice is injection clindamycin, 900 mg 8 hourly plus gentamicin, which is given in the dose of 1.5 mg per kg 8 hourly. If the patient has got sensitivity to clindamycin, we can switch over to piperacillin tazobactam, and ampicillin sulbactam can be given along with metronidazole. It is important that IV therapy should be continued till the patient is clinically improved. That is, there is no uterine tenderness and the patient has been afebrile for 24 to 48 hours. There is no hurry to stop the IV antibiotics before the patient is clinically stable. And that has to be followed with oral antibiotics for at least a period of...
Please.
Hello?
Dr. Richa, please wind up in 2 minutes.
Okay, ma'am. So if there is secondary PPH, there can be laparotomy and repair can be done in cases of uterine scar dehiscence, but it sometimes requires hysterectomy, exploration of the uterus in RPOC and persistent trophoblastic disease, serial beta HCG estimation, and all need to be done. Now coming to post-cesarean infections, which is also very common. The risk factors have already been listed, and wound infections could be either hematoma or seroma or necrotizing fasciitis. So we have to identify the cesarean section infections and treat them accordingly. Antibiotic prophylaxis, pressure wound therapy should be done in cases of obese women where the subcutaneous tissue thickness is more than 4 centimeters, or daily use of chlorhexidine soap after removal of dressing also helps in reduction of multi-drug resistant organisms. Wound hematoma, if found, should be evacuated under sterile conditions. Seromas and all need to be managed accordingly, and antibiotic prophylaxis, especially against methicillin-resistant Staph aureus, must be given. So these are the pictures of necrotizing fasciitis, and a burst abdomen needs to be ruled out whenever a wound infection is there because it needs urgent repair. Endometritis, we have already discussed. Urinary tract injuries are also very common complication of cesarean section, and it has been seen that bladder injury is found in around 0.2% in primary and 0.6% in cases of repeat cesarean section. If left unrepaired, it can lead to fistula formation, which presents after catheter removal if in early cases, and if there is pressure necrosis, it typically presents on the 7th to 10th day. 3 swab tests for location of the fistula site and cystoscopy followed by repair, preferably by involvement of urosurgeon, needs to be done. Bowel injuries also are known to occur, although the incidence is very, very less. And if they are recognized during the time of surgery, a primary repair has to be done. Extensive injuries need resections or colostomy followed by secondary repair. Now coming to paralytic ileus, which is functional bowel obstruction occurring from prolonged hypomobility of GI tract. The patients present with a hyperresonant and distended abdomen and tenderness and absent to reduce bowel sounds. A special mention of Ogilvie's syndrome is warranted, wherein there can be a massive dilatation of the cecum and right colon. And this is the X-ray picture that we are going to get. We can see that there is a huge megacolon over here. The management, paralytic ileus per se resolves spontaneously. Chewing gums in the early postoperative period, laxatives, prokinetics like metoclopramide can be given, but if there is cecal dilatation of more than 10 centimeter, it can result in ischemic perforation of the bowel, which then needs cecostomy and intestinal resection in cases of perforation. Some of the late complications of cesarean section, as Madam has already mentioned, could be placenta previa, scar dehiscence, scar pregnancies, endometriosis, and risk of repeat cesarean section in the subsequent pregnancy. And it has been seen that for women with placenta previa, the risk of placenta accreta keeps on increasing with the number of cesarean sections. Incisional hernia is also, the incidence is inversely directly proportional to the number of cesarean sections done. Now coming to the anesthesia-related complications, hypotension is one of the most common complication and most frequent one also. So the combined approach of a low-dose spinal anesthesia and adequate fluid therapy is the mainstay. But if there is persistent hypotension, which is unresponsive to fluid therapy, we must think of intra-abdominal bleeding, sepsis, or an underlying cardiac cause. Aspiration pneumonia, sudden cardiac arrest, high or total spinal are some of the complications. Headache after cesarean section is most commonly due to post-dural puncture headache. It usually resolves spontaneously. Use of a fine needle, that is a 26-gauge spinal needle, maintaining proper hydration, and caffeine-containing beverages are usually advocated. And the presence of therapy with epidural blood patch is rarely needed in such cases which do not respond to conservative measures. The other differential diagnosis which we must keep in mind while we only think of—
One more minute.
Okay, ma'am, I'll just wind it off. Cortical vein thrombosis is also very, very important. That is one of the complications that we can have post-cesarean section. Now coming to the medical complications, post-operative pyrexia. And when we talk of this, the other causes, the other medical causes also need to be kept in mind. Venous thromboembolism, as we all know that it has, puerperal period has the highest risk of venous thromboembolism, DVT as well as pulmonary embolism, which can present with sudden maternal collapse. So these are the risk factors for development of thromboembolism. And post-cesarean thromboprophylaxis, the RCOG recommends that low molecular weight heparin should be given for thromboprophylaxis for 10 days for all the patients who are having emergency cesarean section and for elective cesarean section in cases if they have additional risk factors. They should be continued for 6 weeks in high-risk women, that is having three or more than three risk factors. And aspirin should not be recommended for thromboprophylaxis in obstetric patients. Urinary tract infections and sepsis. Again, sepsis is again a very life-threatening complication of infection, and the patients might present with septic shock. A quick SOFA score helps in the diagnosis of sepsis, and further management needs to be done. There could be heart diseases complicating pregnancy, and it has been seen that the probability of adverse cardiac event is higher in cesarean section delivery than after vaginal deliveries. Pneumonia, again, because of decrease in the respiratory muscle excursion and due to pain and reduced vital capacity, these patients are more prone for development of pneumonia. Fetal complications include transient tachypnea of the newborn, as well as iatrogenic fetal injuries in the form of lacerations or finger injuries, amputations, etc. can also occur. So to summarize, I would just like to say that post-operative care of the parturient and the baby is very important, as maximum mortality occurs in this period. Complications following cesarean could be surgical, anesthesia related, or medical complications, and high index of suspicion and awareness about the possible common as well as uncommon complications is a must to minimize morbidity and mortality, as well as minimizing the litigations. Thank you.
Yeah, thank you, Dr. Richa. May I request Dr. Hemali Sinha, our chairperson, for her expert comments?
Yes. Thank you, madam. First of all, I'd like to thank Dr. Sadhana Gupta for inviting me to this webinar, and I also wish her all the very best for her upcoming elections. Dr. Richa Jha presented a very elaborate talk on all the possible complications that one thinks of and one doesn't think of. I'd just like to just reiterate a few points because of the paucity of time. When we think of complications, I always like to think of on the table, off the table, and remote complications. On the table, what is very dreaded is, of course, hemorrhage. We are generally, worried about that. And of course, there is a drill for managing postpartum hemorrhage in these cases. Then, of course, injuries also. But what I'd like to emphasize is infection prevention practices, which somehow take a back seat, which are very important. I mean, spending a couple of minutes extra with a proper pre-operative scrubbing goes a long way in preventing infection, instead of, complicating that with a heavy dose of antibiotics. And this I would like to, propagate to all my juniors. And generally, I talk about this. Then I also endorse her view that psychosocial support is very important for the mothers. They should be counseled before cesarean and post cesarean also, which somehow in our busy practice takes a back seat. Then I also agree with the point that modified early obstetric warning signs is a chart that should be put up in every post-operative room. That should be put up in the labor room itself, so that whenever one gets time, one can keep looking at it and one is tuned to doing that. And of course, communication and consent are both very important. We may do our best, but if we don't communicate to the patient and to the attendants, it somehow all goes waste. I think I should stop now because yes, it was a very elaborate talk, and the previous talk was also very, very enlightening about evidence-based on the technique of cesarean section. So thank you very much once again.
Thank you, madam. So I thank our panelists, chairpersons, Dr. Amita Sinha, Dr. Sukanta Mishra, and Dr. Hemali Sinha, and our dynamic speaker, Dr. Richa Jha.
Thank you, ma'am. Thank you for organizing everything. Thank you for giving me the opportunity to speak. Thank you, ma'am.
Moving to the panel. The panel is on difficult situations in cesarean section. We have panelists. Sahiti, please put up the CVs. We have panelists, Dr. Pragya Mishra Chaudhary, Dr. Mukta Agarwal, Dr. Bhavna Tiwari, Dr. Jayati Malhotra, Dr. Sudhir Adhikari, Dr. Sharmishta Gatkuli, Dr. Chandrachur Konar, Dr. Alpana Khetri. And we have expert panelists, Dr. Meena Samant and Dr. Tapan Kumar Maiti. Sahiti, can you please put up the CV slides?
Ma'am, just a minute, ma'am, I'm sharing.
Yeah, thank you. So the moderator is Dr. Sevanti Goswami. She's a consultant gynecologist, laparoscopic surgeon, and cosmetic gynecologist practicing in Kolkata. Former associate professor, Medical College, Kolkata. trained in advanced laparoscopic surgery, trained in cosmetic plastic gynecology, and she was the chairperson of quiz committee FOXY. Next slide. I am the co-moderator along with Dr. Sebanti Goswami. I work in Tata Main Hospital, Jamshedpur. Then we have expert panelists, Dr. Meena Samant. Next slide, please. Dr. Meena Samant, she is the president of Patna Obs and Gynae Society, senior consultant HOD Kurji Holy Hospital, Patna, vice president ISOPAP 2023, chairperson FOXY Clinical Research Committee, Kaminira Oration 2005, organizing secretary Yuva FOXY 2011, organizing secretary of BoxCon 2018. We have Dr. Tapan Kumar Maiti. Next slide. As the expert panelist, he is the professor and head NRS Medical College and Hospital, Kolkata, with teaching experience of more than 30 years. He is an examiner of undergraduate and postgraduate students with several publications in national and international journals. Next slide. Panelists, Dr. Pragya Mishra Chaudhary, who is a consultant infertility specialist in New Life Test Tube Baby Center and MGM Hospital Research Center. Next slide, please. Next slide, please. Dr. Mukta Agarwal, she is the additional professor and unit head in All India Institute of Medical Sciences, Patna. She has more than 45 publications in reputed index journals. She is a UG and postgraduate examiner with publications in Jogi and Indian Journal of Tuberculosis. Peer reviewer. Next slide. Professor Sudhir Adhikari. He is the ex-HOD Department of Obs and Gynae, North Bengal Medical College, ex-professor Medical College Kolkata, Medinapur Medical College, IPGMER Kolkata and Bardhaman Medical College. He has received multiple awards on Emergency Obstetric Care Training Center, Eden Hospital, Kolkata, Master Trainer in NSV, Comprehensive Abortion Care, and examiner in undergraduate and postgraduate exams in different universities, more than 100 publications in national and international journals, and contributed chapters in textbook. Next slide. Dr. Sarmishta Ganguly. She is an RMO cum teacher in NRS Medical College, special interest in high-risk pregnancy, vaginal surgeries, and gynae endoscopy. Next slide. Dr. Bhavna Tiwari, assistant professor, Department of Reproductive Medicine, Patna, member of National Quiz Committee, FOXY, co-chairperson Quiz Committee, Patna Obs and Gynae Society, founder faculty of First Government Center State-of-Art IVF FIXI Facilities of Bihar, multiple awards to her credit and several publications. Her field of interest is laparoscopy, infertility, and ART. Next slide. Next slide, Sahithi. Dr. Chandrachud Konar, assistant professor in Mata Gujri Memorial Medical College, assistant professor in Sri Devraj URS Academy of Higher Education and Research, and contributed to DC Datta publications. Dr. Alpana Khetri, associate professor in CSS College of Obstetrics and Gynecology and Childhood, Kolkata, joint clinical secretary, Bengal Obs and Gynae Society, member of Medical Disorder in Pregnancy, and member of Medical Education Committee, peer reviewer of Jogi. Dr. Jyoti Malhotra, senior consultant, Kurji Holy Family Hospital, Patna, active member of ISOPAP, presented papers in state and national conferences, special interest in high-risk pregnancy. So we have experts in the field of obstetrics, doyens from Bengal and Patna, with and we have a moderator, Dr. Sebanti Goswami. So, madam, let's start the panel.
Am I audible, Moushami?
Yes, yes.
Okay. Good evening, everybody. And first of all, I would thank Dr. Sadhana Gupta, madam, for inviting me to this exquisitely nice program. And thanks to Moushami also for taking up myself as your co-moderator. Now, it's already 9:15 and we are ahead of time. So without speaking much, I would just go into the panel slides one by one. Are my slides visible?
Yes.
Okay. So cesarean section is a very commonly done operation, as we all know. It is unique in two ways because it deals with two lives at the same time. And it is the only operation which we do for a physiological reason. And there can be unpredictable ways we face during the cesarean section or before or after the cesarean section. And if everything goes on fine, the patient party is going to bring bouquet for you. And if nothing goes fine or something goes wrong, then be ready to be showered with bricks instead of being showered with flowers. That's what we have seen in our lives. And I also welcome Maushami to be by my side. We have already declared the name of the experts and panelists. I'm not going into it anymore. Rather, without wasting time, I will directly go into the case scenarios. We have kept case scenarios for discussion mainly tonight. Sorry. Now, there was a study which showed that mainly the difficulties faced during cesarean sections can be categorized into four: difficult access to lower uterine segment, complicated fetal extraction, laceration or damage of any organ or viscera, and abnormal placentation. We have kept the cases depending on these four difficulties only, which we encounter in our time to time. Case scenario 1. A third rural woman. She has got a previous history of 2 cesarean sections, but living issue 1. The first one was a vertical incision at rural PHC, and the child expired after 1 hour. The second cesarean section was a transverse incision, and that child is living. That's 3 years old, and she's pregnant for the third time. Ultrasound report shows 37 weeks gestational age, cephalic presentation, upper uterine segment placenta, normal Liker, hemoglobin 10 gram, other investigations within normal limits. She doesn't have any medical morbidities as such. On examination, the fundal height was 36 plus and floating head, FHS is okay. She has come with mild pain off and on, and she has been found to have been in early labor. Now, you have taken up this case of cesarean section. What skin incision would you prefer? Because she has got 1 vertical incision and 1 transverse incision. I think I will take this up with a very dynamic and junior person first. Shormishta, are you there?
Yes, madam. I would like to go with the transverse incision.
Why? She has got a vertical incision in the past. Why do you want to go for the transverse incision? I agree with you, but why?
Yeah, it's the skin incision that is given vertical, but to approach the lower segment, it is always easy to go with the transverse incision in spite of whatever the previous incision is.
Moreover, because of the transverse incision.
And the placentation, and I am also confirmed that the placenta is not in the lower segment. That's the only indication where I would like to go for a vertical incision. Otherwise, always I would like to go with a transverse incision.
And also to prevent
hernia also.
Yes,
And
that's what I was trying to ask.
chances of hernia.
Yes, madam. It also decreases the chances of hernia. So even if there are 2 types of incision, unless otherwise indicated, it is always clever to go for a transverse incision. Now you have opened with a transverse incision. While opening the parietal peritoneum, you find absolutely there is no space. The uterus is almost plastered to the anterior peritoneum. How would you facilitate entry into the abdomen and access to the lower uterine segment? Bhavna, can we take it up with you? Bhavna, can you hear me?
Yes, ma'am. The question is clear. Ma'am, since there is no space to enter into the abdomen because of dense sedations, I would like to open slightly above the point of, we should open as above as possible in the parietal peritoneum.
You have gone with the transverse incision. Shomishta has already led us with the transverse incision. So with transverse incision, how much high up can you go?
Not much, ma'am.
Then,
this is a sudden difficulty which we have faced now, because if it would have been the vertical incision, we would have gone upwards.
Yeah.
But in this, so we can
Yes.
go from the paravesicles.
Yes.
And paravesical space and adhesions can be taken care of by sharp dissection, by ligating and then cutting.
Yes. Anybody else? Any other method?
Madam,
Yes, madam.
In this case, we have to be careful, and identification is important. Identify the structures, and then slowly we can cut and dissect. Sharp and blunt dissection. Bladder identification is also important. So we have to identify where the bladder is, and then as soon as we can reach some space, then we can enlarge it with our fingers and try to deliver the baby.
Yes, basically the cesarean section adhesions are more in the center. This is the lateral window technique, which we also, take care of during our vaginal hysterectomies. We always go for the lateral window technique, but the lateral space are usually the virgin space. So if you cannot find a space in the middle, try to go laterally. And then, as Madam has said, that we go for sharp dissection. And then as soon as we reach some place where we can enter, there we enter. Now you have opened the abdomen. So we will go very fast, otherwise we cannot finish the cases in time. The surgeon has opened. You have taken care of the virgin space, taken care of the bladder, bowel, etc., and you have opened into the abdomen. Now it is a highly floating head. The surgeon faces a very difficulty in delivering the high floating head. What are the methods you apply to get over this situation?
And the assistant should stabilize, try to stabilize, and instead of giving a fundal pressure.
Let us ask others also.
Okay,
We'll come back to you, Bhavna. Alpana, are you there?
Yeah, I'm there.
Yes.
First of all, yes, I would like to proceed. After the uterine, and first of all, dissection of the bladder is important before doing a uterine incision. And after doing the uterine incisions, the membranes are very slowly ruptured in order to drain the liquor very slowly. This makes the head to get, to descend, and even the delivery have to be done by maintaining the flexion of the head. So if you have this thing, you can instead you can give a small incision, let the liquor to get drained out, and slowly you steady the head. Then and then the incision can be extended further on. And you can also tell the assistant to mobilize the body, the fetal presenting thing, the longitudinal axis so that it does not rotate.
So stabilizing the baby, liquor, draining out the excess amount of liquor by even a small incision, and then slowly. So you have to be very slow. What we do is we become very fast. We become very fast. Now, as soon as we see the hairs of the baby, we become very impatient. That should not be done. We should be slow. Any other method of
you can also take one blade of the forceps in order to deliver the head, or you can put the forceps blade in order to deliver the head.
Okay, then forceps. Any other? Can we
Also
have
vacuum can be used, ma'am. In case of
vacuum can be used, forceps can be used.
Also can be utilized.
Yes.
Scarf can be utilized.
So we have heard about going slow. We have heard about draining the liquor, mobilizing the baby and stabilizing the baby. We have heard about applying a forceps. We have heard about applying a ventouse. Okay. Would you like, often we find that after 1 or 2 cesarean sections, what happens is that the scar would you like to excise the skin scar before going in?
Yes.
We come back again. We come back again to the skin, and I ask this question: that do you routinely incise? Because if you excise the skin scar, the abdomen becomes more,
spacious more.
Yeah, more spacious.
It's more spacious and easier to deliver, ma'am.
Yes. So, do you think a great fundal pressure helps in this?
No, ma'am.
Any panelist thinks that a great fundal pressure helps in this?
It doesn't help, ma'am. It doesn't help.
Doesn't help.
2 cesareans, it doesn't help.
On the contrary, it may in fact cause a greater trouble by moving it laterally, the fetal head laterally, ma'am. So we should avoid it.
It becomes breech presentation, or rotates and it becomes breech, and it's very difficult then.
If it becomes breech, it helps. I think
keeps the baby steady, na? It keeps the baby in a line, so it helps. It helps.
What helps, sir?
It keeps the baby in the same position.
No, that is stabilizing the fetus. That's every panelist have said that stabilizing the fetus before delivering it. But what we were saying that, like, we start calling OT boys and we start calling everybody to jump on the abdomen of the patient and start giving fundal pressure in a very big.
That should be avoided.
Floating head, and that's an unmoving head. Forcing should not be done. That's the
Forcing
main
should
thing.
not be done.
And
Little pressure is
no,
given,
yeah.
but not with force.
Okay, forceps has also been said. Alpana has said that we can use one forceps, we can use two forceps. That's why whenever we go for cesarean section, we should have a Wrigley's forceps in our cesarean OT trolley before we proceed for the cesarean section. And
It is always
vacuum.
kept. Always kept.
Is vacuum safe for cesarean section?
Yes.
Yes, ma'am, it can be used. It can be used.
It can be used.
It is safe.
Dr. Kona, you have been silent for a long time.
No, ma'am, I was listening to all the inputs. No, it is vacuum can be used, ma'am. It is quite efficient method of delivery of the head. We have
But
also
is there any difference in between the vacuum application in normal delivery and that of the cesarean section?
the difference is with the traction only, ma'am. The normal delivery, the method of traction is different compared to cesarean, but then the pressures and the way of delivery, it is
that's the same. Because
Same.
yes, that's absolutely important point which Dr. Kona has said, that the direction of the traction is different. In normal delivery, the direction of traction is tangent, it's perpendicular to the cup, whereas in cesarean section it becomes tangential. That's why what happens at many times we see that it might pop off at 1 or 2 times. Otherwise, the vacuum is safe. Now, we would like to have an expert comment from Dr. Meena Samant that internal podalic version for floating head, any option? Dr. Samant, are you there?
Yeah, I'm very much there. Yes.
So we have talked about many methods. We have spoken about excising the skin. We have spoken about draining the liquor, going slow, stabilizing the baby, vacuum, forceps. Now, would you like to do an internal podalic version and deliver it?
Yeah, that is one option. Definitely, it's one of the options because you have a head, and once you're trying to, negotiate, it may become a transverse. And that time, even getting hold of the feet is something. And just like as you mentioned just now, if on your fundal pressure becomes transverse, all the more better, or a breech, because then delivering out the baby would be easier. As far as the safety of the vent tubes is concerned, personally, frankly speaking, I do not have the experience of using it in cesarean section. I am more of a forceps person and have not found any difficulty applying forceps. And I like to use 2 blades of the forceps when I'm using it, and not use it as a vectors. And here, of course, it's a floating head. 2 would definitely be good.
I agree with you. As it is a high floating head.
Hello.
Yes, sir. Yes, sir.
In internal, I mean, as you said, internal version. So if the head is not in incision line, if it is away from that line, say in angles, that time we can do this internal podal version.
Yes, that also Meena Samant said that when the baby automatically, when somebody wants to give a pressure and the baby comes in an oblique or transverse line, then it is easier to catch hold of the feet rather than struggling with the head. We have all seen that. Okay.
And I want to comment also, once the liquor is drained out so much, if the thing gets dry, the intrauterine compartment gets dry. It's very difficult to, just
Very
rotate
difficult
through the difficult. So you
Sorry.
have to make sure that the liquor, some amount of liquor is still there.
Yes, definitely. Otherwise, you won't be able to rotate the baby inside.
Yeah, definitely. Otherwise, it's not possible.
It's not possible. Okay, but these are all options which we should keep in mind that you can do this. Anybody has got this experience? Initiate uterine contraction with oxytocin drip in physiologic dose?
No.
No.
I mean, these are all available in the literature, but we seldom use it because oxytocin has been found to simulate the contractions of a uterus. But how far it is going to act? Yes, because the method of action of oxytocin and methogen is different. Now, oxytocin it mimics the labor, but how far it is going to act on a uterus which has been cut already is really doubtful, though it is available in literature. That's why I took out this point. And, so learning points will be this, that always make appropriate skin incision equal to medium-sized Alice forceps. That's one of the tips, that a medium-sized Alice forceps is about 19 centimeter. That should be the adequate incision. In case of previous case, it's advisable to excise the previous scar and fibrous tissue. That will give you better space, a modest fundal pressure to fix, not to push. That's the main thing. After rupture of membrane, allow the amniotic membrane fluid to drain out, maintaining the flexion. In case of excessive liquor, make small intrauterine incision, drain it out slowly, then increase the incision, and excision of previous car is good, and dense adhesion, sharp dissection is always preferred in compared to blunt dissection, because we have many times seen that going blunt and blunt and blunt, we can enter into a viscera instead of opening it up. Vacuum is rapid effective modality. Technique of forceps and vacuum in cesarean section is quite different as in case of normal delivery, but both of them are very effective. And now after you are going ahead with this third cesarean section, in a third cesarean section like this, after while opening the peritoneum, something like this picture. Can you see the picture in the slide?
Yes.
Yes,
Yes,
ma'am.
something like this has happened. Dr. Konar, something like this has happened in front of you. Okay. So you see the Foley's bulb in front of you. And so what would you do? And what would you do to prevent such instances also?
Ma'am, the Foley's bulb, I don't know whether I should be saying, I also have seen such a case. Sharmishta madam was there in NRS when I was there. So I have
We
seen.
have all seen all these complications in our life.
Yeah. So ma'am, in this particular case, it is quite obvious that such a thing can happen. It is one of the anticipated complications of previous two LSEs, one vertical, one transversal, whatever. So it is a common complication after delivery. It has to be repaired, ma'am. 2030 vital continuous unlocking or intermittent sutures. We can do it off, and mostly it is a trigone area that will be affected. So yeah, it can be repaired, ma'am. Intraoperatively repair can be done. And it can be avoided, ma'am. There was one question which you had mentioned that the lower segment is not properly identified. There are certain surgical landmarks which can be seen. For instance, if you look at the peritoneal folds in the anterior abdominal wall, we have the median and the lateral umbilical ligaments. Those can be identified to see the position of the bladder as well. So this can happen, but then it can be repaired intraop only.
Obviously, it can be repaired. We have to repair. We cannot leave it like that. But it has
Moreover,
to be repaired. I am
Dr.
coming.
Shavanti,
Yes, sir.
Dr. Shavanti, sometimes we feel the bladder. Sometimes we feel the balloon. Sometimes we feel the balloon to identify the bladder location. So accordingly, we also make the incision.
Yes. First of all, opening as high as possible. That prevents this. Second, he said that we can guide with the urachus, that is the median umbilical ligament. If you can guide, urachus is very well, even in a very plastered abdomen, the urachus is often visible. So if you can guide with the urachus, you can reach to the topmost point of the bladder, and that helps. And sharp dissection always helps instead of blunt dissection. So that's how we prevent such situation. Now, such a situation has occurred, and we know how to repair the bladder. Would any one of you think of calling a neurologist? That golden $1 million question.
Neurologist?
If they are available in the OT, in the
Ma'am, at my center, I would prefer to call them.
Nowadays, the question of litigation is there. Na? If they are available nearby, you can call, no problem. And you can repair
So better
yourself.
to call them.
Yes, Bhavna, what are you saying? I didn't hear.
Ma'am, working in a multidisciplinary center where urologists are easily available, as far as the medico-legal issues also goes, we should call them.
That's the first issue, medico-legal issue. Otherwise, each gynecologist has got an experience of
expertise to do that.
Can repair the bladder in 2 layers and mobilizing the bladder, repairing 2 layers and keeping a catheter. Bladder is a very loyal organ. It's more loyal than the gut. Actually, okay, it will heal up if you have a continuous catheterization with a good antibiotics. But one question which is coming up day by day is the medico-legal issue. That if supposedly it doesn't heal up, supposedly the patient has got a VVF in the future, then whether you can be sued medico-legally, that is the only thing in the back of our mind. Otherwise, we seldom have called urologists in our life. We have another expert, Dr. Tapan Kumar Maiti. Sir, would you call a neurologist if you injure a bladder during cesarean section?
Of course, I will call a urologist, or if urologist is not available, at least a general surgeon. To avoid the medical issues. To avoid the medical issues.
How days have folded that even such a senior professor now says that I will call a urologist, who might not have said this 20 years back. This is what has happened to our science, basically. We all know how to repair, but from the medical legal point of view. And another thing where we need to.
And in the days of CPA, consumer protection, in the days of CPA, we should. Always.
So even if you know how to repair, it's always better medico-legally to call. Otherwise, you can make him stand and repair, but you may call him actually. So, and the thing is that one case where you need his help is where the a big injury has been done and you think that the urethral, the ureteral openings might be compromised, those are the cases where it is always better to call them because they might repair after ureteric catheterization actually. So these were the main things. Most common urological complications, cesarean section, is damaged bladder, and it is mostly done when we are opening up the peritoneum. Opening peritoneum by sharp method seems better always than the blunt dissection, and creation of the bladder flap at least 1 to 2 centimeter above the top of the bladder might help. But we know we all know that when it is plastered, then creation of flap above 1 to 2 centimeter of bladder is often not possible at all. Adequate mobilization and repair in 2 folds. Now, so with this, we come to the end of the first case, and I hand over the second case to Dr. Moshumi. Moshumi, you are welcome.
Yeah. So introducing you to the second case, the patient is admitted in a single person nursing home, previous cesarean section at term with no antenatal checkup and no ultrasound report with her, and patient is already in early labor. So the surgeon, the single surgeon who is in the nursing home, opens up the abdomen, and this is the picture. So now next, what to do? Dr. Mukta Agarwal, would you like to take up? You are the single surgeon. You have opened up the patient. There was no ultrasound report, no antenatal checkup. So this is the picture. Now, what is your next step? Dr. Mukta, Dr. Bhavna.
It seems
It's
a placenta
percita,
in theta percita spectrum, ma'am.
Yes. So now you are the single surgeon.
Ideally, she should have been subjected to ultrasound, but since she's an unbooked case and coming to me and I have already opened, I don't have any option other than to deal with it. We have to avoid this incision near the presence of the placenta. The placenta should be avoided, and so transverse or vertical incision above this site where the attachment is there can be given, and the baby should be delivered as fast as possible without touching the placental site, and clamp the cords and just deliver the baby so that it does not the baby does not get affected. And after that, I would like to leave the placenta in situ like that, and give a fast go for the fast closure of the incision, and then for peripartum hysterectomy, if I have the blood facilities and all available, or I'll call a help from a nearby hospital or center, probably if I have someone to help me. Because this needs several hands, ma'am, and multi-specialty center ideally to deal with this situation. This should not be.
Exactly. So now the incision is you have given a transverse incision. The incision is already made. So there is now Dr. Sarmishta Ganguly. Would you like to go ahead with the cesarean section, or you would like to close the abdomen and send the patient to a higher center?
After I see this situation, madam, I will first inform my anesthetist that this is a case of morbid adherent placenta. I may land up in a severe postpartum hemorrhage. I would like to make a double channel and arrange for blood before I give the incision as soon as possible. I would also like to call for help, and then I would go as high as possible, either a vertical or a transverse, but above the incision line. And without disturbing the placenta, if I see there is much bleeding, then I straight away I would proceed for hysterectomy without wasting much time.
Yes, I think
in this case, ideally, if we see this situation, we go for the delivery by upper segment incision and keep the placenta inside the uterus, close the uterus. After taking out the baby, keep the placenta, close the uterus hurriedly, then go for abdominal hysterectomy, keeping all your helping hands around.
Yes, sir.
Yes. So
fundal incision for the delivery, upper second classical incision for delivery, deliver the baby, put the placenta, put the umbilical cord inside, then stitch the uterus, then go for hysterectomy.
So in this case, there can be problem in delivery in the bladder
bladder is below, the placenta is below. We are going delivery of the baby from upper segment. We have to deliver the baby from upper segment.
No, sir, during hysterectomy, we can have problem.
Yes, Dr.
Definitely.
Mukta.
But we have to take out the baby now once it is inside.
So now we have to assess if suppose the patient is not bleeding, and in the middle of the night we are not able to find an extra hand. You have called an obstetric friend, your close friend, she or he is not available, blood is not available. Then what do we do? And patient is not bleeding. So there is always an option of closing the abdomen
that depends upon the owner of the nursing home, who is a single person in the nursing home, how much he is confident. If he is confident, he can go ahead. If he is not confident, he can send closing the abdomen to nearby.
So there is no shame or there is no hesitation in this.
No,
because
delayed hysterectomy can be done.
He can help in sending the patient and calling the person where he is referring.
Yes.
Where he is referring, he can call to the concerned obstetrician that I am sending such a patient, please take over. Like this.
Even delayed hysterectomy after 3 to 12 weeks can be possible, because the uterine perfusion this thing reduces after delivery, and the placenta in situ might decrease in size and vascularity also. So
that is not particularly possible in this particular case, the picture which you showed, ma'am, because
we have not yet delivered the baby. The surgeon is still thinking whether we refer the patient or we operate. So now there was a situation.
Madam, the patient is referred without taking out the baby.
Yes. Without delivering the baby, there is the option of without delivering the baby. If we do not have assistant, we do not have the right infrastructure, we do not have the blood, we are not prepared for it, we can always close the abdomen without delivering the baby and refer. Now coming to a situation where the obstetrician has found an assistant, suitable assistant, blood has been arranged, and she's going ahead with the cesarean section. So what would be now, the transverse incision is already given. So would you like to give a T incision, or you would like to extend the transverse incision?
With the same incision, go ahead.
Yes. Any other opinion, please?
But we can go for transverse incision. It would be a better extension of the transverse as a T shape instead of extending transverse incision, because there may be chances of extending into the broad ligament and injuring the vessels as well as.
We are talking about the skin incision. We are talking about the skin incision. Skin incision is transverse.
Skin with the same, ma'am.
Yeah. So skin is transverse incision. We can. There are two options. Either we give extend the transverse incision and do a muscle cutting instrument to have space, or we go ahead with the T as per us, our convenience and comfort. Now, what is your choice of uterine incision, Dr. Jayati Malhotra?
Madam, the uterine incision already, Dr. Bhavna had said that we should give it above the placenta. It should be a fundal incision.
Exactly.
And placenta should not be touched. Baby should be taken out, clamped and removed. And then we can proceed after counseling, consent and all, we can proceed with the hysterectomy.
So what would be the choice of uterine incision, transverse or vertical?
No, transverse, in the fundal, transverse incision.
Upper segment vertical incision.
But now the incision is transverse. Skin incision.
You can convert transverse into J-shaped also.
I am telling about the uterine incision.
Ma'am, if it is fundal, it can be transverse also. There is no harm in giving a transverse incision. It can be transverse.
Difficult to give a classical with a transverse skin incision.
Yes.
You can go up with a high transverse.
High fundal transverse.
Yes. Can I request our expert panelist, Dr. Meena Samant, to come up with her experiences?
In this? Yeah, because we can give either, but upper midline is easier to repair because we used to it, and there'll be less bleeding in the midline, because in the fundus, as we go transverse, but the thing is we have to close very quickly and not touch the placenta. That is more important. So depending how up or how your vasculature is, it's coming really high up, we may even have to go for a transverse. High transverse.
Yeah, thank you, madam. So
I just wanted to come in here. Visited Sivan in one of the meetings, and there one doctor did say she opened the abdomen, found the accreta, closed the abdomen without delivering, and rushed her with the ambulance to Patna, to one of the higher centers. So that is something, that option is always there if she's not bleeding. And another time when I had open and it was not a suspected one. I had, with the open abdomen, I waited for at least half an hour before my blood bank gave me a green signal that blood and everything is red. So yes.
Yes, thank you, madam. So the baby has been delivered with an incision above the placenta, and the placenta has not been disturbed. So now, Dr. Konar, would you like to separate the placenta now, or try separating the placenta?
No, ma'am, separating the placenta, I would not try at all. If in this particular case, if it is a case of accreta, percreta, I'll be planning only for peripartum hysterectomy
Yes.
without separation of the placenta.
Okay.
So the idea only would be to hysterectomy, ma'am. So,
So
I won't.
any tips and tricks before proceeding for hysterectomy, so that we've finished the procedure as early as possible?
Early as possible, ma'am. Peripartum hysterectomy itself, it is a difficult procedure with so much blood loss. The visibility is less. Structures, the ureter, all of that have to be taken into account, ma'am. The steps of hysterectomy are the same. You'll be doing a total hysterectomy rather than a subtotal one. I mean, that also depends whether you can do a full or a subtotal, or how you want to do. So,
Ideally, if we can separate the bladder before delivering the baby, then it is of help, because after you deliver the baby, then you can proceed for hysterectomy straight away, as your bladder is already dissected below, and you have and you can proceed.
Yeah, correct.
Yeah. And
So,
we should always aim for a total hysterectomy in this case. Yes, because subtotal again will leave leave a bleeding placental bed, which is of no use. So my question to Dr. Alpana Khetri, would you like to go for internal iliac artery ligation after hysterectomy or before hysterectomy? Any experiences?
For hysterectomy, if you have the, if a senior person is doing, I think internal iliac ligation should be preferred. But actually, bleeding is also from the other vessels, other anastomosis also. So this might not be totally, preventing totally. The bleeding might not be prevented if you try this internal iliac ligation, because some of the anastomosis is still, supplying the lower part of the uterus. So it depends upon your clinical acumen whether you can do. If you have the thing to do the internal iliac ligation, you can go ahead with it. At least it can reduce some amount of blood loss.
So I request our expert panelist, Dr. Tapan Kumar Maiti, to share his experiences after obstetric hysterectomy. Any additional procedures like internal iliac artery ligation?
Yeah.
Is it needed?
Yeah. If the placental extension, there is a lateral extension of the placenta to the broad ligament, then you should approach, after cutting the round ligament, go straight to the lateral pelvic wall and do an internal iliac tie. This is my approach, particularly when there is lateral extension of the placenta in between the layers of the blood ligament. Internal iliac tie should be done. Otherwise, the vascularity is very much high, and if you do not tie, you may be landing in a very difficult situation with uncontrollable bleeding.
Yes.
And second important point is, these blood vessels are very thin walled, so always avoid diathermy coagulation. Always tie these vessels. These two things I should emphasize.
So any other opinion on this? Dear panelists, any other opinion?
The same. The expertise is important.
So depending on case-to-case scenario, we can decide.
Routinely, we do not need it.
It is not absolutely necessary, as Professor Tapan Maiti has suggested. When there is extension in the lateral wall, that time can be done, but it is not 100% for all cases. Case to case, there is individualization of the cases.
Yes, it is not a routine procedure. Only it should be done in case of lateral extension. And after hysterectomy, peripartum hysterectomy,
If there is no
If
oozing.
there is generalized oozing, then interiliac tie should be added, and it should be bilateral, not unilateral. But prophylactic interiliac ligation in routine cases that may cause again excessive bleeding, because you should think of this, because the opening of collateral circulation is almost immediate, resulting in this high vascular situation excessive flow of blood, and that have a chance to increase blood flow for the time being, before, as there is immediate opening of the collateral circulation in the deep pelvis. It's a deep pelvis. So one should not do this as a routine prophylaxis.
Thank you, sir. And for this case, consent for hysterectomy is very important. And along with consent for hysterectomy, need for blood transfusion in the ratio 1:1:1, followed by a proper post-operative care, a proper level 2 care, critical care bed is needed for the patient to recover. So handing over the third case to Dr. Sebanti. Madam, let us wind up the third case. It's already turning 10.
Yeah, we'll wind this up in 10 minutes time. Now, while opening up a case for cesarean section, what you find is that there's a myoma in the lower segment, and there are two interstitial myoma on the anterior wall of the upper segment, one at the fundus also. So what to do? I would call up Dr. Mukta first. She has been remaining silent for a long time.
Yeah, thank you, ma'am. Since it's an undiagnosed one, and we should take the consent and arrange proper blood and blood components. And since the lower big myoma is in the lower uterine segment and coming in the incision line, that has to be removed. And upper two myomas, those can be left untouched. And there is a risk of PPH, so we should have PPH drugs, blood products, and consent for hysterectomy if needed.
Now, I would take the opinion of all the panelists one by one, that would you go for this myomectomy? All the panelists will do, because it's in the lower segment. Until we do this, we cannot take out the baby. But one by one, what about the other two? One at the fundus, one in the upper part of the uterus. Dr. Mukta, I'll take opinion from everybody and close the session. Dr. Mukta, would you remove the upper fundus fundal myomas?
I don't think those myoma needs to be removed at this setting, because these are the smaller ones. And
if you have a big myoma, so you would remove a fundal myoma if it is big. Then you would go and also. So you are against removal of fundal myomas which are not in the lower segment, right?
Yeah.
Okay. Bhavna, would you remove the upper fundal myomas which are not coming in?
I will remove only those fibroids which needs removal, even in cases in which the patient is not pregnant. Suppose after the delivering of the fetus, I have time, I have the fundal myoma which is large enough and which will need myomectomy later. And I will remove. I'll remove.
Okay, so she is in favor. Jayati Malhotra, will you remove the fundal myomas?
Madam, actually the myoma which needs to be removed, which is necessary for delivering the baby.
Madam, we all agree that the lower segment myoma needs to be removed.
And
we
the
have
fundal one I will remove only if it is symptomatic. Previously also it was symptomatic. Otherwise there's no need to remove.
Not even if it is a big fundal myoma.
Yeah, if it is a big one, then she must have been symptomatic only. Then we'll remove.
Not necessarily. Not necessarily. A big subserosal myoma might be asymptomatic.
Then no. Then I won't remove it.
Okay, she is against. Dr. This Konar, would you remove the fundal myomas? Dr. Konar, are you there? Dr. Chandrachud Konar, are you there or are you not there? I think he's having some issues with network. Meanwhile, I'll ask Alpana. Alpana, will you remove the fundal myomas?
Yes, if you had asked the same question 3 years back, I would have said no, I would not remove.
But now you are smart enough to remove it.
Now I'm standing here, yes. If the fundal fibroid is big enough, and if I think it's very tempting to remove, I will remove it.
Definitely. Okay. Now, Dr. Konar, am I audible to you? You are not audible to me because you are muted.
Yeah, sorry, ma'am, there was a power cut. My Wi-Fi got disconnected.
I understood that. Did
Yeah.
you see the case? This is a case where you have opened and you have seen a big lower segment myoma, which all the panelists have agreed that we'll have to remove it before taking out the baby. But this woman has got 2 other additional myomas in the fundus. Will you remove them at the same sitting or not?
Very difficult to comment on that, ma'am. It depends on the situation, ma'am. If I don't
What
think
situation?
I won't personally remove that, ma'am.
Oh, he won't. Okay. So we have got Sharmishta. What will you do?
I will do only if I have taken a consent previously that these removals after explaining the patient. If she has given a consent, then only I will remove. Or if accidental.
Sharmishta, do you take, supposedly she was diagnosed before with a fundal myoma and the lower segment. Myomectomy consent means for myomectomy. It doesn't mean that I will take consent for a lower segment myoma separately. And do we do that? We take a consent for lower segment myoma. We take a consent for upper segment myoma. When we take consent for myomectomy, we take for consent for myomectomy, isn't it?
Yes,
so?
I will remove.
Supposedly she has given a consent for myomectomy. Will you go for removal of
I will definitely remove, madam. And I have learned this technique from you and Sudhir sir only.
Oh my God, then I'm coming back now to my teacher only, Dr. Sudhir Adhikari sir, who has taught me this Caesarean myomectomy and made me, clever enough to do this. Sir, the last word will be from you first. That should we remove the fundal myomas?
Yeah, I play always with the balls. So definitely I'll remove. Whether it is in the fundus, whether it is in the posterior, anywhere I'll remove. As much as there, I'll remove all.
Because we are of the school who think that she will require a myomectomy in the future, so why not come?
Once baby is out, and you close the incision line, and my uterus gets well contracted. Moreover, as we are afraid of blood loss, there is vasopressin. We diluted vasopressin to inject all around the myoma, and then we can remove. There is hardly any blood loss. Not even 50 to, not more than 50 cc.
Yes. And
moreover, we are utilizing electrocautery also. Electrocautery also. That also can reduce the blood loss. So and it's well contracted. As you'll find in Bonnie's literature or his students, stalwart he has also said that after in postpartum, after delivered the baby, uterus gets well contracted. Whether you give oxytocin or not. So there is hardly any blood loss in doing myomectomy.
Yes, as sir has quoted from Bonnie's book that is written there, that uterus is ready to tackle any hemorrhage maximally during the postpartum period of a female rather than in any other part of her life. So I would like to close up after having expert comments from Dr. Meena and Professor Maiti. Dr. Meena, what is your comment about Caesarean myomectomy?
I think by and by we all are becoming more, expert and experienced in doing cesarean myomectomy. Only last week I was reading the annual census of my department, and I found the cesarean section myomectomy was way ahead of the myomectomy as such in our department. So that's how the scene is changing now. But yes, even when I do, I am not as maybe an expert as Dr. Adhikari, and I am more selective. It's if it's on the lateral side, a very big one where I think I may encounter a lot of hemorrhage. Maybe I'm not using the technique which sir is doing. So it's not essential that I would be going for myomectomy for each and every myoma. But yes, if it's one of those, a big sitting there to be taken out, whether it is even if it is at the fundus, and especially if it's a subserous one, it's all right. And even those bulging inside, we can do the internal nucleation. So techniques are coming up, and you become more and more experienced in doing it. Yes, but it's not a compulsion that you have to, at least for me. But yes, more and more we are going in for myomectomy these.
Okay, what about your comment, Professor Maiti?
Unless you gain expertise and experience like Dr. Sudhir Adhikari, it is convention that not to touch myoma. This is a convention. But to gather experience, you have to start somewhere. I will advise the juniors to start with a myoma which is predominantly subserous. To start with this, myomectomy with a myoma which is predominantly subserous. In that case, you will gain experience and confidence, and after doing several such cases, as Professor Subidhi Adhikari has gained experience in Eden Hospital Medical College, I was working with him a few months, and he is a brilliant expert in this Caesarean myomectomy, I should say. And before, one should also see how the expert is dealing with some cases, at least 10 cases, then you will venture. Without seeing straight away, you go to the that I am doing it as it is written in Bonnie's book, or nowadays people are doing it. No, you have to see how expert is doing at least 10 cases, even if complication, the excess hemorrhage occurs, how he or she tackles the situation. That is very important.
Correct, sir. And that's true for any operation. We always see first, then we assess, and then only we go and do. That's true for Caesarean section also. We don't jump into Caesarean section on the first day of our life. That's true for it. And as sir said, that I have been working with Dr. Adhikari for a long time, and this was way back in 2006 that we published the paper first. That was a small collection of cases, but then we went on doing it, and definitely it was a very rewarding OT. It's already 10 o'clock and it's time for dinner. So we would like to wind up. Life is unpredictable and you never know what is coming in front of you. So do not ever get too comfortable, but always be ready for a change, because change is the only thing which is permanent. Thanks to all of you for an active discussion. Thanks to the experts for putting on your comments from your experiences. And thanks to my co-moderator, Dr. Moushumi, for calling me up, inviting me to co-moderate with her. And lastly, once again, thanks to Dr. Sadhna Madam for inviting me to this session to moderate. Thank you.
We also thank you and Moushumi and Dr. Sadhana Gupta, and we all wish our best for this coming elections.
Yeah, it was an excellent panel, Sevanthi, and with expert panelists, and everybody shared their experience so lively. It was a great panel.
Thank you, ma'am. Thank you, Sadhana ma'am. I think she has left, or she's not audible.
No, I am here.
Oh, thank you, ma'am. Thank you very much.
I am very much here. So wonderful discussion, Sevanthi and Moushumi, and great panel.
Ma'am, shall we go ahead with the vote of thanks?
Yes, please.
So today's evening, winding up discussion on Caesarean section. So it is a pleasure and honor to deliver the vote of thanks. Chief guest, Dr. Manju Geeta Mishra Madam. Guests of honor, Dr. Ashish Mukhopadhyay, Dr. Alka Pandey, for sparing time on a Tuesday evening, leaving their practice and joining and enriching and blessing us. Then the speaker for session 1, Dr. Aditya. The chairpersons, Dr. Neelam, Dr. Rita Jha, Dr. Ram Prasad De. For session 2, this Caesarean section technique, we have 3 chairpersons, Dr. Avinash Chandra Ray, Dr. Pramila Modi, Dr. Bishwajit Guho, and our speaker, the organizer, Dr. Sadhna Gupta Madam. Then session 3, the speaker, Dr. Richa Jha, we thank her. With the chairpersons, Dr. Amita Sinha, Dr. Sukanto Mishra, Dr. Himali Sinha. I thank the moderator for the panel, Dr. Sevanthi Goswami, the experts in the panel, Dr. Meena Samant, Dr. Tapan Kumar Maiti, and all the lovely panelists, Dr. Mukta Agarwal, Dr. Bhavna Tiwari, Dr. Jayati Malhotra, Dr. Sudhir Adhikari, Dr. Sarmishta Ganguly, Dr. Chandrachur Ponar, Dr. Alpana Khetri. We missed Dr. Pragya Mishra Chaudhary, who could not join for a last moment emergency. And last but not the least, I thank our SHIELD team, Sahiti Priya, Tulika Tripathi, without whose help, everything regarding the entire help from IT, making of flyers, sending of links, everything was done by them. So I thank you, Sahiti and Tulika, for your help. And last but not the least, all thanks to the organizer, Dr. Sadhna Gupta Madam, whose efforts and whose push this webinar could take shape. Thank you so much.
Thank you, Moshmi, to you for like all the effort and coordination. And thank you once again, Bengal and the Patna Society. And it has been like a home and a very, very close association with both societies. We have been the part of each other's every meeting, conference, so many things. And looking forward that we all together can really make difference at every level, right from the ground to realities, our Indian health statistics to all expertise and the evolution what we have. So we have so many endoscopic surgeons, we have infertility specialists, we have ardent teacher, academician, every sort of expertise is with us. And this is the time that we go hand in hand and do the best for our country and for our fellow OB-GYN. So again, gratitude for being together today. Gratitude especially Dr. Avinash, Vishwajit, Meena and Dr. Amita for all the thing, because it is President Secretary who come forward and all the faculties, and gratitude for always being together, and we look forward to a great association. Thank you very much.
Thank you, ma'am. Thank you very much, ma'am.
Thank you.
Thank you. Bye.
Chandrachud, good to have. So we have Mukta. They are the budding young people, very like a very good academician. Chandrachud corner, Dr. Hiralal's corner. So we look forward to the young generation to coming more and more, and many like me. I am not saying a wonderful presentation by Richa on the postpartum care. How hard effort she took, and always we emerge with the young stars at everything, and that is also a gain. For all of us to have the young persons in team, and we like
Thank you, ma'am. Thank you.
Thank you, ma'am. Thank you.
Thank you. So very good night. We can
Good
say
night.
good night, and
Thank you,
Good
madam.
night.
Would like to
Thank
see
you,
you as
ma'am.
President
Thank you.
Foxy. Thank you.
Thank you, ma'am. Thank you.
Thank you.
Thank you.
Thank you.
Good night.
Good night.
Good night.
Good night. Thank you very much.
Thank
thank
you.
All the
you.
best.
Thank you, Rita ji.
All the best, Sadhna ji.
Thank you.